Dear friends, welcome on board of Four Surgeons Club. We begin our live stream that is sponsored by Johnson & Johnson, and I have my personal sponsor today. It's the 50-year-old whiskey to make my English more better. We are very glad to meet our audience, and this evening we have a very special webinar for our team. It's the first English-speaking webinar. Dear friends, welcome on board of Four Surgeons Club. We begin our live stream. Okay, so today we will discuss, as you know from the trial of this event. Today we'll speak about the ideal total mesorectal excision, about the rectal surgery, and we will discuss this problem in the expanded format with our invited guests. And let me please introduce them. We are very glad to welcome our Serbian friends, Professor Mavlen Janic, the Chief of Coloproctology Surgical Department from General Hospital Pančeva. Also, it's a great honor to greet Miljan Keranic, the Assistant Professor of the First Surgical Clinic from Belgrade. Dobar dan. Also, I would like to represent our friend from Moscow, Badno Bashankayev, and majority of our audience know him. He is the Chief of Surgery of GMC Hospital from Moscow. And finally, I would like to present to you and represent our special and very outstanding guest, the great man and the wonderful mentor, our great teacher, Professor Amjad Parvaiz. Welcome, Professor. I suppose the majority of you heard the name of Amjad Parvaiz, and we also speak about him on First Surgeon Club's meeting. And we, many surgeons from the formed USSR, had the pleasure to be his trainees, to be the pupil of this wonderful mentor. He made a lot for development of modern surgery. His approach in surgical training really works. We know that it works, and we know that many surgeons implemented Amjad's style in their hospitals. Dozens of colorectal surgeons from the formed Soviet Union learned the standardized laparoscopic colorectal surgical procedures from him. And in last years, he is extremely passionate with the robotic colorectal surgery, and now he is a founder of the Robotic European Colorectal Society. So everybody who has a practice in the field of colorectal surgery know and respect our dear teacher and our mentor, Amjad Parvaiz. Very, very warm welcome for you, Amjad, and today you will be the main person of today's broadcast.
Thank you.
Nice to see you all, dear guests, and I want Artem to make your greeting. Artem, we'll listen to you.
Hello, I'm pleased to welcome our guest today, and especially the main hero of today's webinar, Amjad Parvaiz. I remember very well my first visit to Portsmouth in 2015. I saw brilliant laparoscopic surgery. More than 15 years before, I began working in the clinic of Professor Alexandra in Moscow and assisted in hundreds of lap operations, began to perform this operation myself. But what I saw in Portsmouth streamlined my previous view and experience in laparoscopic colorectal surgery. That day I saw a Da Vinci robot in the corner of operating room and asked Amjad if he was operating on a robot, and he answered yes, and I will definitely demonstrate it to you. Surprisingly, after 2 years, I began to work in the clinic on Da Vinci robot, and again Amjad, along with Dmitry Gladyshev, became the main mentors for me since they have been to Lisbon many times. Every time I was there with pleasure and happiness, and look forward to today's webinar, lecture, and video discussion. So I give my word to Ilya.
Ilya, we'll listen to you.
Илья?
Ilya,
Не слышно.
Ilya, please.
Михаил, может, на паузу, да, или как-то.
Some problems with.
Слышно? Fantastic.
Yeah.
Да.
Yeah. Okay. It's very happy day for me, and I'm grateful to all our guests today. I especially want to know that Professor Amjad Parvaiz influenced all colorectal surgeons in Russia and especially in Serbia. I first met him in 2014, and since then, my idea of correct colorectal surgery has absolutely changed. Today, I'm very glad to communicate with all of you and will enjoy Amjad's operations again. Good luck and thank you.
Thank you.
Dear colleagues, I'm pleased to welcome everyone to our Four Surgeons webinar. First of all, I want to thank you for your time and you will spend today with us and our viewers and the experience that you will share today. I work at HPB Surgery Center for more than 15 years and I have been operated laparoscopically in colorectal surgery more than 2 years. Last year I was twice in Center Champalimau and spent more than 2 weeks there with Amjad, Bill Hilt, Nuno, and the whole team of Center gave me all their straight and knowledge. I'm very grateful for you because it personally motivated me very much and gave me a strong motivation for further development, especially in rectal surgery. Unfortunately, in Ukraine, we have no centers such as this level and no mentors and training programs in colorectal surgery. So I listen to our guests with pleasure from Serbia, Russia, and about their experience in implementing such programs. I wish everyone great broadcast today and hope that our viewers will like everything.
Thank you, friends. So we have today we have international meeting: Serbia, United Kingdom, Ukraine, Russia, and Georgia. So cheers,
Kalmykia.
cheers,
And Kalmykia.
and he's Russia. He's a Badma is a real Russian guy. So thank you very much. Thank you very much, my friends. Let me please introduce you the plan of our today's webinar. So at the first part of this event, we'll have three presentations from our guests. Ladlen and Milian will tell us about the LabSerb program, the outstanding program of implementation of colorectal training in one country. I suppose it's a very interesting, very great experience. They will tell us about their statistics and about their implementation of this. And of course, Amjad Parvaiz was the main coordinator of this program. It is a very interesting experience, and we'll hear their presentations. Then we'll listen to Badma with his short presentation about the future plans of the development of colorectal surgery in the Russian Federation. And after that, our broadcast will be fully provided to the Professor Amjad Parvaiz, and he will show us a lot of original videos and tell us about his view on the perfect laparoscopic and robotic TME procedure. So we can start, and the first presenter will be Professor Madlen. So we are ready to hear you. Good luck. Запускаем, Миш, наверное, да?
Can you give me a first slide? Dear colleagues, LabServ is a national training program of laparoscopic colorectal surgery with goal of surgeon education and raising the level of this field of surgery. Officially, it started in April 2018 under the patronage of Ministry of Health of Serbian Surgical Association. But before that, 6 surgeons in 2015 unofficially started under the leadership of Professor Amjad. In the next 10 minutes, I would like to present a SWOT analysis of LabSEP project at the beginning in 2015 and in 2018 when we become official national program, and now. My name is Mladen Janic. I'm coming from Serbia, as probably everybody knows, but I would like to repeat that we are on the small yellow dot on the left corner, down corner of this slide. In the purpose of better understanding, we can apply SWOT analysis to LabSerb or Lab Color RUS project to identify internal and external factors important to achieving an objective. Next slide. It is essential for all members of team to honestly and objectively identify a list of strengths and weaknesses of organization or company like LabSerb or Lab Color RUS, as well as opportunities and threats in external environment, which help us when we're planning to achieve the objective. Before I present SWOT analysis in the beginning of LabSerb, I would like to show you in a few slides how we started. So it all started in Moscow in 2012 when I met Professor Amjad Parvaiz for the first time. While watching him operate live, I realized that this was the best surgery instructor that I ever had a chance to observe. A year later, at the 5th Pancho Coloproctology workshop, Professor Amjad for the first time visited Serbia. He did 2 operations together with us, and in that time, laparoscopic colorectal surgery was being done sporadically in Serbia, and there were no training instructors. Majority of the hospitals didn't have the necessary equipment. We started with borrow laparoscopic stock. The only thing that we had was enthusiasm and the idea to make up the huge disadvantage. In 2015, at the 6th workshop, Professor Amjad was again our guest. In the conclusion of his talk, he made a visionary, precise guideline on how to start national training program, similar to LabCOP project in Great Britain. In that moment, there were more than 200 surgeons in audience attending, and it present an open call for Serbian Surgical Society. So, hook was set. A few months later, at the suggestion of Professor Amjad, we organized in-house workshop in our hospital for future instructors. We called leading colorectal surgeons for our country. Those who came were the ones ready to teach themselves and others. The core of Future LabSerb project was formed. And here we have a situation in 2015. Strength of LabSerb was Professor Amjad and those 6 surgeons, highly motivated by the idea of themselves learning and teaching others in a way said by Professor. On the other side, you have a list of many weaknesses, and I don't want to read them all, but probably it's very similar in every country. On the other side, also we have opportunities, and in our country, it was a good time for a project like that because it's a very big interest in patient and surgeons, and on the other hand, no training instructors, as I already said. But also we have some threats, like some of established professors and surgical association, because in that time LabSerb was not officially recognized association. 6 of us together with Professor, it's like 7 samurai, I like to say. We learn through practice the meaning of standardization and modular training in laparoscopic colorectal surgery. But most importantly, we started building the team. And in between operations, it was a really lovely discussions took place. Our unique contribution to the concept of team building was the formula. Serbian restaurants, we call kafana, with traditional Serbian music, put together with hiking. And from the beginning, our work was carefully monitored by our Russian friends and fully supported. At the 7th workshop in 2017, we showed our initial results. We already had significant number of operations done under the LabSerb protocol. We were ready. Strong and united team was required to let our voice be heard by Minister of Health of Republic of Serbia to present our idea. And we let Professor Amjad to convince Minister fully to our idea. This happened in April of 2018 and the project was officially started. So, in the April of 2018, situation was significantly different than a few years earlier. Many of our weaknesses were converted to strength, but still some weaknesses remain and some new ones appeared. It was very important to recognize and focus on the new weaknesses and threats, rather than to be blinded by success. To explain to you those weaknesses and threats, I have to give you a picture of Serbian hospitals network. You can see Serbia map here on this slide and 40 surgical institutions in which colorectal carcinoma is operated. And here are 6 of us and our hospitals. We were the first training centers defined back in 2015, but now becoming official. LabSerb diploma were awarded to the first instructors, 4 of us. And after that, we start with workshops in our country, headed by Professor Amjad and his assistants, always with the host, always present, and who are evaluated for LabSerb diploma. One of the key features of this project is focused not only toward university centers and big university clinics, but towards any hospital in Serbia that shows interest in fulfills requirements to develop this type of surgery, which is clearly shown on this slide, in which you can see the list of institutions in which training has been completely successfully. LabSerb coordinator, Professor Miljan Čeranić, will give you after me all statistics and our results. I just want to say that because we recognize our weaknesses, we work very hard in that time. And in I think in a short period of time, we included almost all hospitals in our country in our LabSerb project. And for the end, where we are now, compare it to 2018 when we start officially, situation now is much better. We are very proud of the results achieved. We can say that LabSerb was complete. Can we say, it's a question, can we say that LabSerb has completed its mission? I don't think so. Some of my so-called friends ask me why we still need an instructor when we have done so many operations. And to which I reply, Why would Novak Djokovic need an instructor, coach, when he is the best in the world and knows everything about tennis? I think connecting with that, currently, our biggest weakness is that usual surgeon general believe, I think in Serbia and probably in Russian too, believe and practice that after achieving certain level of proficiency, they don't require any further instructor monitoring. So we put self-confidence, too much self-confidence, in this moment as a weakness of our LabServe project. So in the future, I think that we have to continue in the same manner like we did until now. And instead of conclusion, I just want to say my personal opinion. What is the really necessary for success of this type of project? It's of course dedicated group of surgeons, and I think it's important that it's not too big, not too small, and that depends how big is country. For Serbia, we showed that 6 of us. I believe it was a good number. I don't know for Russia, maybe 10 times more. And I think it's very important to have a leader and leading instructor like we have, and we are extremely happy that we have Amjad with us. And of course, it's also very important, in my opinion, beneath all I put in our SWOT analysis, but I think it's very important connection and support of key politicians, Minister of Health, government, or whatever what is necessary for success. Because without financial support and everything what is necessary, it's difficult to support that type of project. Thank you very much for your attention.
Thank you.
Thank you.
Great talk.
Thank you. So I think we need to continue. And the next presentation, this is statistics.
My name is Miljan Černić. I'm associate professor from First Surgical Clinic, and I'm national coordinator of LabServe project. And now, after Mladen, I will tell you something about our results. Surgery is not only LabServe is not only surgery; it's a philosophy concept, and we tried to resolve many problems with diagnostics, pathology, anesthesiology, and after all, it's problem with to make a database and to show you all results. Anybody who wants to know something about our project and our idea. First, that's database. This is database, and it's Google Forms. I made it in Google Forms together with Milan Janic, and according to our talking with Amjad and Jamil and our friends, and we talked and fixed our database. Now we have, I will show you just a second. Maybe this is one moment only. We talk about Clavian-Dindo classification of complication, and we have a table, and we have these fields, and somebody, especially young doctors, will choose only one possibility, and we have very clean data, and we can easily make statistics, and you can see 56 data fields, and some fields mandatory, and some fields if you have data, you can feel it, and that's very important. And we could help Russian friends to do it similar way. Because when surgeons feel that data, they if you put them to do it, they only clean data. It's not possibility to do it the other way. And first slide, it's very important. You can see number of operations. The first year only 41, and last year almost 10 times. And we have in this year only 100 operations due to the COVID infection. And you could see this is tumor place, and the most common indication is sigmoid tumor. And next slide, you can see the indication. Adenocarcinoma is the most common indication, and the other second indication is polyp not suitable for endoscopic removal. And you in this slide you can see type of operation. The common is anterior resection and total mesorectal excision, and the second is right hemicolectomy. Next slide. This is real statistics. We have statistically significant increase number. It's first period when we before the official project start, when we only train the trainers, and after trainers start to do in the other centers, and we have statistically significant increased number. Age is no statistically significance. In the other period, we start to do patients with higher BMI. No statistical significance between male and female. No statistical significance ESC grade. This is very interesting because after the project start, we start doing more patient statistical significance with previous surgery, and we have statistical significance number of patients with advanced carcinoma. We decreased operative time. Length of stay was similar with statistically significance. We have no statistical significance in number of retrieved lymph nodes, in blood loss, and R1, R2 resections. No statistical significance in conversion. In percent of hard Clavien-Dindo complication, 3B, 4A, 4B, and 5. And Clavien-Dindo 5 is that we have no statistical significance between these groups. In conclusion, I can say only that in November 2015 and 2018, we have successful and safe adoption of laparoscopic technique for colorectal resections. And in the other period, after April 2018, we have statistically significant decrease number of colorectal resections, patient with higher or bigger BMI, with previous surgeries, with advanced carcinomas, and less operative time. This is my presentation, and we after all presentation we can discuss about our problems, but I think this is very successful adoption of this project, and I want to thanks
Sure.
Professor Amjad Parvaiz, because he helps, and his team, especially with his with Jamil and with Sophocles and Professor Mishkovic and whole team. I want thanks because he's very, I think, one of the most successful programs in Serbian surgery. Thank you very much.
Thank you very much for your nice presentations. And if you don't mind,
Thanks.
I have several questions.
Okay.
It's the question for both our Serbian friends. Please tell us, are there any hospitals in Serbia that refuse to become a part of LabSerb program? And what was the reason? If there are some kind, if there are
Probably it's a
such
question
kind of
for me.
hospitals. For both
For
of
both of
you.
Hoćeš ti prvi, Mladen?
Can
Ajde.
Can you hear me?
Yeah,
Yes,
Yeah,
we can.
yes.
Yeah, it's a good question.
So are there
Uh,
are there
real
any hospitals who refuse to become the part of LabSerb program?
Yeah, only few. Really, only few. In the beginning, it was a big fight between some, let's call them old-fashioned professors, and how times go on, people understand that it's a very good program, and especially after watching live operation on our workshops. So now in this moment, maybe only 2 or 3 hospitals not yet in our project, but I think even them will come very soon to be a part, because now maybe 95% of all surgeons in Serbia accept the LabSerb as a project and accept.
Great.
It was not in the beginning.
Great. Thank you very much.
I say in
Yeah,
2015,
sure. We
it
understand.
was very big.
Yes.
It was a very big fight.
The progress is coming, but not quickly. We will all know about it. And what do you think about the receiving of international trainees in LabSerb program? I think that this question can be interesting for many students and residents who are listening today.
I think
Who
that
listen to us
Serbia
today.
generally, we are very open, and especially, for example, I can say in my name in our hospital, we have that practice in the last 10 years. I'm doing that with Professor Mr. Richard Cohen from UCH, University College Hospital in London. We are calling that chicken exchange, and we are doing that some of our young surgeons going in London to see modern surgery, and some of his young doctors coming in my hospital to learn some traditional surgery, but now in the last few years very good modern laparoscopic surgery too, and we are doing that almost every year. In that way, we are very open and ready to do same. We already try with Alexei Karachun. So two of my young colleagues spent 1 month in his hospital institution with him, and they were really very happy that had a chance to observe his operation. We are very open to accept our friends from Russia, for example. I think it's we Badma and Alexei, we discuss about that, and we are ready to start that type. I think that we don't need any official. We can do that like we are doing in the last 10 years.
Okay, I would like to ask Milian. Milian, from your
Yes.
presentation, we learned that you perform laparoscopic procedures almost in all patients with colorectal cancer. And are
Yes.
there any contraindications for laparoscopic approach in colorectal surgery for cancer for you right now? So, are there any kind of patients who you plan to operate in the open way,
High
not in
higher
laparoscopic way?
higher BMI is not now real contraindication. We
Okay.
can do it safely after big work and so many operations. Previous surgery is also no contraindication. Real contraindication, if you have so many lymph nodes, positive lymph nodes, we can see it in CT scan. And with retroperitoneal lymphadenopathy, and it's real and so big tumor, maybe 10 centimeters and or 15 centimeters is I think I talked with Amjad, and really is not idea to do laparoscopy.
Thank you. And one question, and after that, I know that Kirill has one question also. For this question, I want to ask you to answer very briefly, maybe in one sentence. So, can you please tell us about the main difficulty during implementation of the LabServe program? Main difficulty in your scenario? Main
Uh,
difficulty. Main difficulty for these 5 years, or maybe in beginning.
main difficulties is because we have maybe old-fashioned surgeons. They don't like changes, and
Yeah.
you must have somebody like Amjad who is doing very nice surgery, and they can said only this is good, but you must learn, and that's very
So
good.
the main
And
difficulty is the old-fashioned guys. We have
yes,
the same problem.
but
I don't agree.
you must be very good to talk and give them chance to change. That's
Okay. Okay.
very
Thank you.
important to talk with people, and that's most important thing, because if you said okay, you're old fashioned, your problem, your that's not good way, because everybody has a chance to do it. That's a good way to everybody work this good.
You
Okay.
know,
Okay. Thank you very much. Yes. Yeah. Sure. We'll listen to you.
yeah. When I start my first question when I met Amjad, my first question: am I too old to start to learn laparoscopic surgery? And he asked him, who is the oldest of your students? And he asked, if I'm not wrong, someone who was 62.
What about Bill Hill?
And I don't know. It's difficult to put a limit. I'm 61 now, but I catch a last wagon in my train in last moment. And I think even 61 and 62 is not too late.
Yes. Okay, thank you very much. Thank you very much for your nice presentations. And now we'll listen to Badma Bashenkayev, and he will tell us about plans for Lab for Russia, or Lab Russian program. So, Badma, it's your time. You can start.
It's my turn. Thank you, guys. You've done that fantastic joining us in that fantastic meeting. I'm very happy to see so many friends. First of all, I would like many for my respect and sincere love, professional and human love to the who is up right to your screen, the guy who changed his he has now mustaches, you know that. He's fantastic. Yeah, I don't know why you did that. It looks funny, but it looks good. It looks cool. Okay, my dear friends, let me present something that's completely not new. We're doing something extraordinary. We're doing something repetitive, and we're learning from the giants that I'm standing on the shoulders of. So I'm trying to use, plastic. What we have now is a complete copy or replica of something that I've seen outside of Russia. As you all know, I hope I've been in colorectal surgery long enough. And in 2011, we already published something with Dr. Steven Wexner, my father, and beloved champion in any laparoscopic surgery, Sergei Baido. Sergei Viktorovich, my дорогой любовь и respect. We've published something that sort of made this for all my life, future life in education, and we decided that everything what we do shouldn't be like I had in life. My training in surgery was a very Russian way, I would say, or you can call Eastern European way. When I wanted to learn surgery, I was, going to one OR to another OR, seeing one surgery or another surgery. No one actually installed or tested education. I was the only one who wanted to be a surgeon, and thank you, my mentors who were my chief of departments or my leaders in the department. They never actually made any borders for me. I was asking, can I see phlebology? Sure, go. Can I see the laparoscopy? Oh, sure, go. Sure. And nobody ever cared what I actually see. But lucky enough, I've seen the phlebology, and I've seen Professor Khatьков, Igor Evgenievich, who is chief oncologist of laparoscopy, and I think that's who actually changed my mind. So, and then when we got a bit older and we got a bit fat, not all of us, but we got a bit chubby, I've seen different surgeons already, and I've done my way in research, done my way in surgical education, and I understood at some point, and I thought only one, but no. Now you see persons on that who got to the same point. We are in a but not in the straightforward right way, I would say. English is not my first language, and I would say Russian is sometimes not my first language. Trying to be polite, but we want to change something. And the city of the St. Petersburg, or some of you know, city of Leningrad, we had very bright guys. We have bright guys who live there. We have some guy who is on the left side of the screen, the second from the top, with a beard, and the Ilya Chernikovsky, who moved from St. Petersburg to Moscow, and that city is very emotional for me. I will let you know in a bit later why it's so for me. We decided to do something else, not else, but different to what I've seen in the typical Russian conferences. Um you see these fantastic faces, very nice, very bright surgeons, good scientists, and they all friends of, we can have 8 screens over here. Actually, it's not 8, 108 screens we can show. And we decided to do something else, something a bit new, but it's not new. We've asked leaders of colorectal surgery, of laparoscopy, to join us in lap color, which is just a replica, something that's seen in different countries with some Russian accent, I would say. So the idea is it's a short, very condensed, very compressed, very concentrated course of colorectal surgery for the guy who is a bit, he's already a surgeon and he wants to know the most updated topics in colorectal surgery, and he wants to gain some skills, but he already knows how to do laparoscopic appendectomy, mastectomy, or hernia repair, and that guy is our audience. The Thursday is didactic, and those who can read, you can see that we asked our chief major guys to open the conference, and we asked Mladen Yanish to come and to present about lab. And then you see all pictures of our beloved friends who are showing, who are not showing, they're sort of teaching us what's the state of the art treating of colorectal and rectal surgery right now in Russia and in the world. You can see all leaders here. Alexey Karachun, Bikan Khatsev, who is running right now the all Russia rectal oncology surgical registry. They do it to Alexey Karachun, important. Dima Golovkov, who is the rural but not regular surgeon in Voronezh, who is running a colorectal stent. Use Zamidli, our friend, buddy, who is chief of #1 by numbers maybe now colorectal department in Russia in State Oncology Center. And these friends, some of these friends you see on the screens on the right and on the left. So Thursday condensed into didactic. For who don't understand, I'll shortly explain what we've done in Russian. Первый день был очень дидактический, очень объяснить, что является самым лучшим и правильным способом лечения колоректального рака в различных его проявлениях. So actually it was the Thursday, but the first Thursday after the dinner, after the lunch. So the second part of the Thursday is the same, and what we installed, we show live. In my dream team, the best education is to explain what you have to do, and then to show how you have to do it. And we have Professor Polovinkin and Roman Murashko, both locals from Krasnodar. They showed and left hemicolectomy. Those were good cases. And the second day is cadaveric course, which is a bit new, and that's Russian accent. So Thursday was didactic. Our students, about 50 to 200 something, they were and dedicated 12 from those hundreds. They were the second day to cut course, and we had 4 freshly frozen cuts, actually well prepared, and we had Ilya Chernikovsky, Zamali, Dmitry Bez, and actually, our guy who found they help 12 students to do left hemicolectomies. And it was successful enough. I think you can ask our colleagues who were there, and their feedback is very nice, really good for me. Mlade was there. We had different audience. We had new surgeons. We had experienced surgeons. Nice audience. Very good feedback. Ilya Chernikovsky was always active. He was asking questions to to all speakers. That's the slide from and as you can see on the top, on the peak of the iceberg, you can that's the surgery you do on yourself, and those are successful surgeries. And everyone thinks, oh, you are a great surgeon. You were born like a surgeon. You are under the star of the surgery from the childhood, from the kindergarten, you were in you to do surgeries. Unfortunately, it's not that. So you have to follow that big educational part. And Mladen already explained lots of things. I'm sure was the same. We have so many things to do before one surgeon can do his own surgeries. I'm completely against the Eastern way of allowing to do surgery to a new resident right away. I think it's unsafe. I think it's I wouldn't allow my relative to be that patient. Okay, I'm sure that anyone who is doing big advanced laparoscopic colorectal to be that iceberg below the small remarks about our course. That's a slide, and you see that there are terms of how selection to the program of education of advanced laparoscopic surgery would be formed. But if you follow that small in the Skype conference, right there, you see the small face. I will make it bigger. That's our friend and buddy and brother in surgery, and fantastic person. We love him a lot. Andrei Pavlenko. I think that Ilya, it was the last conference he participated. So
Yes.
our body wasn't feeling well, but thanks God he had time. He presented the idea of школа практической имени Андрея Павленко in that presentation. For that, and I love this guy, and you all people love this guy, and I'm sure he's very happy seeing us doing this conference. So Andrei, his ideas, and you all know that this conference, what we have right now, the webinar is the part of Школа Pavlenko. We had very nice feedback. We had about 200 surgeons coming, different levels, and 12 of those were happy to be in cadaver course. I think my last slides would be saying thank you to the sponsors, to our organizing university, to my beloved Первый медицинский канал. Without those guys, it won't be possible. But again, let me show you some very cool and very nice lady, Victoria Krutova. She is vice rector of Kubanский медицинский вуз, Kubanский медицинский институт. She's supporting our educational efforts, and she is welcoming our next Lab Colorus that we're gonna have. But I cannot tell you the date because we have this COVID epidemic, and when it's going to be over, and we'll repeat. And thank you very much, guys, for allowing to present here. And I'm happy to be here. I'm sorry, I'm sorry to be emotional, but that was a very good conference, and I hope to repeat it again.
Thank you.
Thank you very much.
Thank you.
Thank you very much. It was nice presentation, and I suppose it's time to start the main part of our webinar. It will be several videos from Amjad Parvaiz. So, dear professor, the broadcast is yours. You are the Tamada, so we are listening to you.
Okay. First of all, can you hear me, all of you?
Yes, we
Yes,
can.
yes.
First of all, I'm really grateful, that so interesting me to come and speak to you. I haven't been to Russia for a number of years, and it was even before the time of COVID. So I can't really blame COVID for everything. But it is very nice to be back with you guys and seeing some very familiar faces, people I've spoken to, and people I've known for years. I was before the broadcast, I was talking to Artem, and I sort of said to him that some of my best students in laparoscopic colorectal surgery are in Russia. So, I feel very attached to Russia as a country because I have a lot of stakes there, because I think there are very, very good surgeons. Some of them do this better than me, and I have no shame in admitting it. So I'm very glad to be here. I think Badma mentioned this name and showed his picture, and I think I would like to start my presentation owing to this guy who was my student at the beginning, became colleague, friend, and everything else, and the chap who really, I personally think left too soon because he had so much to contribute to this world, and world need people like him because people who makes the difference are the people who are needed right now. He spoke to me at length about the training program which some of you are involved in running, and I'm very grateful to see you do that. And we wanted to meet around St. Gallen's meeting last year, and unfortunately he became a bit ill and he couldn't make it. But like Badma said, wherever he is, which I'm sure is a better place, he's looking down and thinking it's worth a crack. So, I would like to start what I'm going to do this afternoon by just reminding us that we have a very finite time being around in this world. Nobody's going to be here forever. And if we remember him for his contribution to education. And I hope that people around this sort of screens or table or people, whoever are watching it, would make this their mission to sort of expand and teach others, because I think this is the way to do it. So, Mladen showed you a map where he showed you a big corner of Europe. So I thought I show you something as well, because a lot of people sort of say, where is Poole? And I say it's close to London, and they say, well, this is mainly London, but it's not actually. You could see that this is where Poole is. This is where I work partly every month in England. And I live here where this sort of blue dot is. This is the edge of New Forest. So I come around this traffic light and then take this road, and then I come along to work like this. Takes me about half an hour. So I'm there few days every month. I'm also working in this place where some of you have been, which is a fantastic place to come. Weather is obviously a bit different. And I work with some very, very interesting people there. So I'm going to talk to you about rectal cancer and talk of both technologies, laparoscopy and robotics for that matter. But I'd like to put this into context. And the context really for me always have been anatomy, because I genuinely think anatomy holds the key for whatever we do it and whichever way we want to do it. So the precision surgery is the concept, which is true for me. Minimal tissue trauma, minimal tumor handling, and if it looks good on the screen, it usually works. So, but if you ask patient, what really matters to them, of course, most of us, if we are on the receiving end, we would like to come into hospital and leave hospital without complications. So we are interested in leaving hospital without cancer and without complications. All of us are interested in living longer. We are interested in living longer and longer because nobody wants to die. That's the truth. But increasingly, we are more interested in living better. Gone are the days where you could take the cancer away and give permanent bags with a urinary catheter for life or a perineal colostomy for life. Nobody's interested in that anymore. They want to know that what quality of life they would have, and it has a huge bearing in what we do to our patients. So let's see if it moves. Right. Now, I'm very lucky really to live through two revolutions of surgery. You know, I was a trainee in early 1990s when I came from South Africa to England, trying to learn laparoscopy. And this was the debate that was going on mid 90s. And some of you who are very near to my age, and Muladen is definitely close to my age, as suggested, that this was common debate within most circuit. They say open surgery is very well established. There was a lot of published evidence, oncologically safe, cheap, very quick to do, and everybody accepted it in terms of patient acceptance and society acceptance. And they spoke of laparoscopic colorectal surgery with these problems. You know, new technique, longer learning curve to become good at it. There was some initial literature saying port site metastases, so people use that as an excuse of not allowing this to develop in the unit. Of course, it was expensive. And certainly in England, there was a huge skill gap that existed because we had to go elsewhere to get trained. Now, but it has stood the test of time. Laparoscopy now has become gold standard for colorectal cancer patient within UK, for example. We did lots of trials, and lots of trials have shown that the short-term outcomes are better. It is oncologically safe. And up until recently, few years ago, NICE came up with this guideline to say the treatment of choice for colorectal cancer should be laparoscopy. And if the hospital can't offer it, patient would move, and with patient, the money would move. And that was a very potent stimulus for people to learn laparoscopy. Now, you asked the question, I think it was Ilya who asked the question to Milian to say that what was the most important factor when you look at labs being implemented? What was the rate limiting step? And the rate limiting step is this, Ilya, threat of change. Nobody likes the change because we always perceive change as a threat. And I believe that if I don't, I allow the change to happen, I may be left out of this. And that's the human nature. It doesn't recognize any language, it doesn't recognize any culture or nationalities. This is the core of Homo sapien selfish gene. You know, we all like to be relevant and nobody wants to leave that relevance. And laparoscopy is a problem for people, or it was a problem when it was coming in. So people said that laparoscopy has to show that this is better than open surgery, which I find it extraordinary, argument. And for that, we did number of trials. We did cost study, color study. We did classic in England. And we know now that the back of these trials that short-term outcomes are better with minimal invasive surgery. That's period. Nobody should even sort of argue with this. Nobody's going to sort of talk about this. Now, not surprisingly, all of these trials have not shown that it is superior oncological outcome. Now you ask yourself, why should it show any superiority? The cancer has not changed. The anatomy has not changed. The tool is different, but the anatomy is exactly the same. So why we still insist that I would only adopt this if it shows better oncology to best outcome for open surgery? But when we talk of best outcome, we always think these are the results of Bill Heel. But open surgery is also done very badly across the districts. I know this for a sure fact because I trained in those districts in England. So this is an important thing to remember. Now, I showed you what happened in England. So at the back of NICE pushing this through, this is slightly older slide, but this is a slide I borrowed from HAS data. This is 4 or 5 years ago, where the proportion of laparoscopic colorectal surgery increased from under 5% now to nearly 60 to 65% of all cancers in England are attempted laparoscopically. Now, remember, this is hospital-acquired data. This is input by the surgeon, and there is a bias of we over-reporting it. But if you take, this is both for colon and rectum. If you take rectal cancer out of it, certainly the proportion dropped to well below 50% with self-reported 25% conversion rate. So there is a problem for rectum, whether we like to admit or not. And this is what I would like to sort of focus the next few slides to sort of give you an example. I showed you how it all became possible from 2003. This is important to recognize that with those years of sort of changes, the technology improved, people who were doing this became better at it. Fellowship started in England. More and more data published that this is a good technique to do, and people started demanding this operation. But it never became cheap. That's the most interesting thing. You know, if you compare the whole argument that this is an expensive operation, many years later, it is still an expensive cost. It is not as cost neutral as open surgery is, at least for hospital cost. Now, what are the challenges? I could actually take away the laparoscopic word from here, and I could just say challenges of TME. This is constant for any form of operation. Exposure is a problem. Retraction of tissue is a problem. Energy source, what energy source to use? Radiotherapy add to the difficulty. Somebody who is higher BMI and have mid-rectal cancer, a male patient, he's technically a challenge. Stapling problem was a big problem in the beginning of the experience. And I remember Strasbourg publishing a paper many years ago with 17% anastomotic leak rate with multiple staple firing dividing the rectum. And that became like people were hanging on to something. My open surgical bosses were hanging on to anything that will come out of it. They say, look, the leak rates are high, so we should not be doing this. And that's probably the reason people are looking of doing this operation with a number of other ways. I mean, classic obviously didn't help. Classic data showed that the circumferential resection margin rate for rectal cancer laparoscopically was about 20%, 25%, although they have shown since that the overall survival has not been different. Now, with this, recently, these couple of studies came in. This is an a la carte trial, which is very interesting study because an American study for the first time showed the academic world the familiarity of a concept called non-inferiority. We had not heard this before these papers got published. This is an Australian and New Zealand study looking at T1, T3 rectal tumor, comparing the quality of the specimen between lap and open group, saying that laparoscopy does not match the concept of the specimen quality for open surgery. And they said it should not be recommended for those. Just about same time, my American colleagues published this. This is an XGOG study, some very famous name in this sort of paper, you know, if you look at it. But if you look through the paper, and the details really are, you know, the devil is really in the details. So if you look at it, and you look at positive circumferential dissection margin rate for lap group in this trial is 12%. Which everybody around the table would admit that this is probably on a higher side. Usually it should be a single figure. And more importantly, have a look at rectal perforation rate, nearly 15.5%. That's a huge proportion of patient where you are perforating the specimen. And when I spoke to Steve Wexner, who's one of the co-author on this, it was in Moscow, in fact, when we were involved in a debate, and I asked him this question directly, that surely, you know, based on this paper that they have published, which is a randomized controlled trial, it is a level of our evidence, saying that laparoscopy is not good enough. Have you changed your practice now to do open surgery? And he smiled and he said, no, I haven't, because we don't do 16% perforation. It was other guys who did it. That's the good thing in life. You know, there is always other guys who would make up the numbers. And he's partly right, because in America, and Badma would probably know this better than some of us, that the volume of practice done by most surgeons in the counties is very limited. Sometimes you could do 3 or 4 rectal cancers a year, and still be considered as a colorectal surgeon. I think this is part of the problem with these studies and trials. Now, at the same time, this is very interesting. I've shown you two studies. They're both non-inferiority studies. You know about this, I'm pretty sure. And this is a meta-analysis, came from Paris. All three of them were published in JAMA, one after another, basically saying exactly the same thing. This is a meta-analysis in JAMA looking at 14 unique RCTs, looking at the quality of TME specimen, comparing laparoscopic and open surgery, coming to the same conclusion that based on available evidence, the risk of achieving a non-complete mesorectal excision is significantly higher in patients undergoing laparoscopic rectal resection when compared to open surgery. So that's what came one after another. Now, you have to ask this question, is laparoscopy that bad then? This is level 1 evidence. And if we go with science, none of us should be doing this any other way than open surgery. The problem really is this, in my view. The operative technique is not standardized in most institutions. And there is subspecialist centers who do high volume of work, and they produce excellent outcome outside these randomized controlled trial. And you have to ask yourself why they are better than others. This is a common sort of thing. Have a look at this trial. This is a trial from our Korean colleague. This is a very well designed study, ran over 3 years, mid to low rectal cancer, post chemoradiotherapy. 117 laparoscopic arm, 117 open arm, and primary endpoint was 3-year disease-free survival. Right? Look at the design. This is, none of them were lost to follow-up. This is a slightly, it should blow up, but you get an idea. The most important thing was this, that they look at that conversion rate 1%, CRM positive rate under 3% in lap group. Not significant, but at least very, very respectful, even in locally advanced tumor, so to speak. Now, when this trial is presented to us, we in the Western Hemisphere always hide behind this excuse and we say, well, they are Korean patient, they are easy patient, and we have difficult patient. That's not true. If you go and watch your Japanese colleagues or Korean colleagues or Chinese colleagues, they are dedicated high volume centers who do 500-600 rectal dissections, and they do it in a very standardized way, a very anatomical way, and it is no surprise that they would become good at it. So it can be done. Look at this, equivalent disease-free survival between the two groups, equivalent overall survival between the two groups, and similar local recurrence. This is our own data. This is rather than using reviews and meta-analysis, let's look at our practice. This is our own data for standardized approach in total mesorectal excision surgery. I sent this paper to one of the British journals, earlier in our experiences when we were trying to publish a long-term outcome. And I got very flattering remarks from the editor and reviewer sort of saying, these are excellent outcome, but we can't publish this here because this is a single surgeon, single center outcomes, which are not reproducible. This is a British way of telling you they're not going to publish your outcomes. So I had to go elsewhere. So we went to Europe, and within this, what I did was this is not only my patients. Then I took 3 of my fellows who trained with me and who were doing independent practice, Nunu, Taz and Anil in those days when they were there. And they went on, and I took their data as well. Look at this. The group here is nearly 300 cases of mine. This is 100 cases of the guys who left me and became independent consultants. Why it should be any different? We all like to think that this should be different in specialist hand, but if you train well and if you learn with purpose, you are able to reproduce this outcome. For me, the conclusion hold the key for this data. Our local recurrence rate was 1.5%, conversion rate again 1.5%, as you would expect. Our CRM positivity rate is 3%. Conclusion for me is the key, that laparoscopic TME procedures provide excellent long-term survival, but a standardized approach has the potential to improve outcome by setting benchmark, providing step-by-step method for surgical training. And I think that's where the real crux is. Then we looked at high-risk patient. People said, well, that's okay. You can probably pick easy cases, and that's why your results are better. This is a publication in a pipeline which hasn't got out. So we looked at high-risk patient in our experience. 313 patients, 227 fulfilled the criteria, and high-risk mean BMI more than 30, tumor below the peritoneal reflection, people having neoadjuvant chemoradiotherapy, and previous abdominal surgery requiring a reoperation. So this is a significantly high-risk group. And we were able to show that if you apply the same standardized approach, the only difference is perhaps 7 mil more blood loss in high risk patient, and median length of stay was 2 days more, which you would expect. Locally advanced tumor, they are likely to stay a bit longer. Everything else exactly the same. We also look at long-term survival between the two groups, very, very similar as you'd expect. No CRM, no statistical significance here. Local recurrence, you can see 2.4% in high-risk group. Recurrence-free survival is nearly 100% in low-risk group. So you come to 2020. I showed you this slide before. All I have done really is I have changed the headings at the top. This is where open surgery was. I put lap there. And this is where lap was. I put robot there, because this is exactly the same debate which is happening in Europe now. And I, for the last few years, being doing robotic surgery, so I've been asked to come and talk about robotics. And everybody asked me the same thing they were asking people in late 1990s. The robot has to show this, that this is better, Well, why it should show that this is better? The anatomy hasn't changed. And cancer hasn't changed the way it behaves. So if you have a foresight and you predict what you have seen from the history, where do you think this debate would go? There's only one way this will go, whether we like it or not. So we started off by looking at our practice, and I'll come back to this thing time and again. For me, this is the most important part. At the time, we had SI system in 2013, and people said, oh, you cannot do the whole procedure robotically. You have to do multiple docking. You have to do hybrid technique. Lots of my colleagues were doing the flexure, the mobilization of the colon and the vessel laparoscopically, docking the robot for the pelvic part. And they say this is the way it has to be. But I looked at Sohan Kim, who was doing them with a flip arm technique, with a single docking, and we thought, no, we would not change anything. We would keep the same step of operation. We'd just change the tool. And if the technique is good enough, we should be able to do this. Now, Jameel Ahmed published this paper with me when we looked at the first 100 cases. We went a step further. We divided the operation into module, and we tried to standardize each module. This is a publication describing 3-step standardized approach for splenic flexure mobilization. It doesn't have to be for robotic. This can be easily applied to laparoscopy technique. So the idea really is that you divide them into steps that are measurable. Then we looked at some of the data to find out where the marginal gains would be with the technique that has changed a bit. So this is a study published from us looking at our laparoscopic data and comparing it with urological outcome, urogenital outcome, comparing lap and robotic. Sophocles published this with us. It shows better nerve preservation score for men and better sexual function rate scores for men. Now, admittingly, whenever you do any of these studies that ask people to fill the questionnaire and particularly score themselves about their sexual function, men always tend to give very high scores. We have a habit of doing it. Whether actually we have high score or not, that's a different debate. But it showed that there was a better nerve preservation in robotic arm. We also look at this particular issue. If you remember from ROLAR trial, it did not show any improvement in conversion for statistical significance, but it did identify, however, the subgroup of people, obese people with mid to low rectal cancer, men, and it shows that they had better outcome, but the sample size was small. They could not show the statistical significance. This is the data from our unit, which looked at those particular high-risk group comparing lap and open. Look at this high-risk group. It was not a randomized controlled trial, but a very well-designed study in the end, because almost similar demographics for everything else between lap and robotic groups. And we were able to show that even within our hands, we could show a higher sphincter preservation rate, and it became more obvious when the stapling device from the robot came in. So we were able to sort of staple low and low using those new staplers, but the rest of it is as you would expect. Now, this is Sohan Kim. He's published his very interesting paper last year looking at propensity score, and he showed that perhaps this long-term survival feature better in robotic group as compared to his laparoscopic practice. This is on univariate multivariate analysis, but this remains to be seen whether this is replicated in other hands or not. So there are marginal gains within the specialty itself, but the most important thing is this: the marginal gains require a lot of practice, it requires a lot of volume, and it requires very honest reflection and collection of data to demonstrate that. You know, my colleagues from industry, and some of them might be listening into this, I'm not too sure. They always would like to think that I should be saying that you press the button on the robot and it would do Bill Heel's operation. We are a few years away from that automation yet. Robotic surgery is great, but you also have to remember that your mistakes also are in high definition and 4K for everybody to see. So you can't do bad robotic surgery for a very long time. Precision surgery is the concept. I genuinely believe that MIS approach, whether laparoscopic or robotic, depending upon what opportunities you have in your hospital, this is a better approach doing rectal cancer surgery. Teaching and training would bridge the skill gap, and this is what we are all interested in, and I hope this would be the case in Russia as well. There would be increasing acceptance from both public and profession. I'll finish off by giving you some take-home points. The take-home point for me really is anatomy. Anatomy holds the key for everything. Homo sapien have not changed the anatomy for the last 250,000 years. We are not going to change in a hurry. So, we all can be rest assured that the ureter would be in the right place, the IMA will still come off the aorta, and the CRM would be exactly the same. So, a Russian rectal cancer look very similar to Serbian rectal cancer, to English rectal cancer. They all have exactly the same anatomy. Standardization of operative technique is a key. When I was a relatively young guy, I was very interested to visit big centers because people would tell me that Brendan Moran is a very good surgeon, Bill Heel is a very good surgeon, and I used to go and stand in a queue and stand at the corner of the operating theater trying to pick one thing that would make me brilliant. And to my disappointment, I never saw anybody show me one thing that would make them what they are. But there was one thing in common in all of them, and that was that they did little things right. Attention to details. You can bring any operation to an end. It's not a punishment. You really got to enjoy it to do it, and only then you would see that the result starts to change. Also, I genuinely believe there is no point having a technique that nobody else can do it. This would go down with me in few years. I'm a very good surgeon because I'm telling you so. We all like to think we are very good surgeon, but our goodness really have to be demonstrated in the hands of our pupil. And it is really an immense pleasure for me when I sit down and I watch people I have trained. Some of them do this far better than I do, and then I say, well, it is worthwhile doing this, because if I am around or not around, it makes no difference, the technique would stay. The marginal gains that we all are constantly asked to produce only come with purposeful practice. This is what I genuinely believe, and this is what I personally teach to all my trainees and everybody who work with me. I say the same thing. I'll finish off by showing you this little sentence. We started our discussion very interestingly with the possibility of threat. I genuinely believe that only change is eternal, perpetual, and immortal. The rest of it is very arbitrary. Thank you very much for your time.
Thank you.
Thank you.
Thank you. Thank you.
Pleasure.
As always, dear professor, you are not only the mentor, you are the great philosophy guy, great philosophy man. You always speak about everything in a very particular and very special way, and thank you very much for your presentation. It was very nice. I suppose that we will answer you some questions after your video presentation. So if you are not so tired, I suppose we are looking forward to listen to you more and more. And if you can start with your video presentations. Thank you.
Okay, so we can put up the first video, please, and then I'll talk you through. Okay, so I chose some of these videos. This is a modular approach or the stepwise approach, because a lot of people who would be sitting in different part of the world wants to see this. So we do medial to lateral approach, and we would start by patient positioning and probe placement. And most of you already know this, but some of the audience may be not that experienced. It would be useful for them. We use modified Lloyd Davis position. And if they don't have a previous midline incision, I start with an umbilical cut down and put a 10 millimeter 30-degree scope here. 5 millimeter scope in line with umbilicus, 5 millimeter scope in the port above the line of the umbilicus here, which becomes your left hand. And then this is the working port, which is a 12 port, 2 finger breadth medial to the bone after you've insufflated with the gas. And in Western Hemisphere, we mobilize splenic flexure routinely. So I end up putting a port higher up there for retraction of the pelvis and also to complete the splenic flexure mobilization. This is the standard technique. Any energy source you can use. If you look here, this is an air, and the idea really is to look at the back of superior rectal artery. The start is the clue. If you start well, the whole operation follows. You can use a hook. You can use harmonic scalpel, as you saw. If you can name the vessel, I think you should clip them, because then you can sleep better at home. So I know some colleagues use energy source to take the vessel, which is absolutely fine. This is the white line of Girotas fascia, over the top of the kidney. I take the vein high at the origin, and this is really for lengthening purpose, not for oncology. And just 2 centimeter lateral to the vein origin where the clip is, you always find pancreas. And if you're not careful with the left hand, you can lift the pancreas forward. So I put a gauze over the pancreas, then undo the lateral mobilization at this stage. Again, traction, counter traction, and a skiing-like motion. Mobilize the colon, get into the lesser sac, and when you see the bruise in the lesser sac, you will see your gauze, which is just there, which you put at the top of the pancreas. So then you complete your flexor mobilization coming around it. This is very standardized way. I showed you these steps. They are done by 2 different trainees of mine. I'm basically holding camera. It doesn't really matter who does it. They have to reproduce the same way. For TME part, I start at the back first. I start posteriorly. Posteriorly, the operation is between these 2 nerves, in my view. This is somebody with no radiation. You can see it's a dry pelvis. And it's like a paintbrush that I have with a monopolar diathermy hook that I use at 20 watts. Very low voltage, just separating embryology. If I hit the bleeding, it only means one thing, that I have missed the anatomy. It doesn't mean anything else. It doesn't mean that this artery was not supposed to be here. We are wrong more often. Once I've gone way back posteriorly, I mark it on the right and on the peritoneal reflection, 2 centimeter above the peritoneal reflection. You can just about see this here. This is the right nerve being pulled in. And if you watch me, literally just like a reluctant touch that you are separating, this is your assistant from the left upper quadrant 5 millimeter port providing counter traction. Now you come from the left side. Remember, you have done quite a lot of that from below already. So there the risk is if you have too much traction here, you can cut across this left nerve, which is very easy to do, believe it or not. Look at this left nerve hanging. So clue for me is the round shape of the specimen. Anything that is not round globular belongs away from me. That's how I gauge what belongs to me and what separates from me. If you remember, some of you might remember that the group in Strasbourg produced this T-shaped retractor, about 12 years ago. And I looked at it and it cost 1100 euros at the time to get this. So we started just hitching it with a straight proline stitch as you hitch the female uterus in female patients. And this turned out to be a very important step for me, because in doing so, what I was able to do is to ask my assistant with a little pledget on their instrument to go deeper with me, to work very, very close in a small narrow space, just like that. See this little pledget there, avoiding trauma? You are outside anovillous fascia, shiny package anteriorly at the back of seminal vesicle. If the tumor is posterior, you can divide it. You don't need to stay that far out. Left nerve again. Don't chase this here. You'll end up too far out. Rounded shape of the specimen. Gentle painting brush-like technique. Trying to separate. Look at these presacral veins. Again, the right side. Now, to me, the pelvic right side wall in male patient is a real challenge. Not the left, not the front or the back. It's the right side. Look at the nerves. You are staying inside the nerve, and now you are posterior. You have to come forward, because if you don't come forward here, you can see the big veins here. Very easy to go into these big veins. See this twitching? The pelvic floor is twitching. I shared this joke with some of you in the past. One of my trainees asked me, how do you know you've reached pelvic floor and you should stop? I said, start twitching. He says, whose pelvic floor, surgeon or the patient? Right? So I say, whichever twitch first, you must stop. So this is an important step to release the anococcygeus. This would allow you to staple this in 2 firing. This is release this part. Unless you do this, you would have difficulty in stapling it. Right now, you are right down into anococcygeus groove. You can use this fantastic machine. If you are worried about making a hole with diathermy, people worry about making a hole if you are just stroking the rectal tube down. And then once you are clear all around, then you can do a digital examination and then staple it. So I would, this is an old video, but I'll show you the concept. The concept is very simple for me. I divided from 12 to 6 o'clock in 2 firings rather than from side, because if you go from the side, it would always be an oblique cut, because it is not a 90-degree articulated stapler. Whichever stapler we use, I use Echelon and Endo GIA, doesn't really matter, whoever give you whenever you are there. The idea is front to back. So if you look at it, it's front to back division by just pronating your hands. At this, wherever we were operating, we were given this stapler, we use it. I'll show you the different stapler, same outcome. So 45, people say, why don't you use 60? Well, the problem is the pelvic floor would not let you go in 1 firing unless it's a female, in male patient. And you end up dividing 90% and having a dog ear, which is not a good idea. So if you see here, you divide it with the second firing, and then you use, I use CDH 29 gun to do the bottom stapler. And this is a technique to do the stapler. When you come in, you come to the side of where the two are meeting. So you don't come through the staple line, you come from the side of it, and you just engage it, knock it forward, and then wind it down and do a flexible sigmoidoscopy. So that's a pretty sort of standardized way of doing ATME. So if you go to the next video, I think we can show the laparoscopic videos first, and then we can have a little discussion before we move on to robotics one.
Okay.
So if we play the second video, okay, this is the second video. The vessels are already done. The flexure is already mobilized. This is a T2 tumor. This is one of the congresses I think we're operating on. And again, boringly similar. You really got to enjoy it. Otherwise, it's a punishment. So don't rush it. You can if the IT guys are, if they can speed it up, it doesn't really matter because you could see it. Again, slim person, everybody thinks are very easy. They are easy, but they're also very challenging because the mistakes you can make are very easy because the planes are far more closer. So you almost have to be that much vigilant if you get a very slim person to operate on. Again, chase the air, touching very slowly, very reluctantly the back of the hook. And by the way, this is not the only way. This is what I often sort of say to all my trainees. It is not my way or highway. It is just one of the ways to do it. And you can use any energy source. You can use harmonic scalper or any other energy device. They're equally good. I genuinely think the reason I do it with this is that I am able to pick my mistakes much more easily because it would bleed. That's what the monopolar diathermy is for. It's for precise dissection. So do the back a long way, as I showed you. Look at that. It's all done between the nerves. I don't do the left side at the beginning. And the reason for that is that sometimes specimens start rotating if both sides are mobilized at the same time. So mark it here again with reflection here, gently marking it. You can, if the guys are, the IT guys, if they want to sort of double speed it, it's entirely possible. They can just speed the video. I'm sure these guys have control. That's good. There it is, the right nerves. This is what I was saying. Right pelvic nerves. You have to do back first a very long way for you to have a reference point. Unless you don't do that, it's very easy to get lost here on the right side. See what I'm doing? I'm looking at back as a reference and I'm painting it inside the nerve plexus. Gentle painting, allowing the specimen to be released. Again, traction, counter traction, gentle painting between the air. Just opening it up. And again, you would just carry it forward all the way. This is the right nerve again. You saw that in the first video. Same again. It's the nerve that exists in every man. And the man happiness depend on this nerve, So make sure that you don't have unhappy patients. Inside the nerve, gently painting. Sometime when it is bit tethered, I use electric current, which is yellow pedal, like a pure current. So you don't have dissemination of the current. So it stays true when the nerves are very close. Now again, just if you remember, you've done the back long way, you're doing the front, and between front and the back, there is a reference point to join. Again, very gently, no rush, I often say to the guys, there's only one emergency that you can disturb me for. If my wife call and say the house is on fire and the fire is quite big, only then I'll come home. Everything else can wait. Now, left side again, gently, traction, counter traction. And if you see the bruise, because everything is done from below already, you already have done everything from the other side. All you have to divide now is the peritoneal reflection on the left side. See this mark here? I deliberately come halfway through. Look at this. This air would take me here. Don't go there. Inside the air. 2 layers of the air. Stay inside the air. And do the top first to join. And then follow the bottom hand. The bottom hand would just come separating the nerve plexus. You'll see it much more easily. Now, I mark this, if you notice, at the beginning, so I don't go distracted by a 30-degree view going this way. You will see this once this dissection progress a bit further. What do I mean by following the shape of the specimen? Now, the nerves don't go back into the specimen. The nerves run straight. We all know this. That's why I never get sort of confused with this idea. Watch this now. This is the left nerve. This is inside the nerve. And that's the round shape of the specimen that I'm following. Gently doing this. Now, you can do this with an open technique. You can do this with robot. You can do this laparoscopically. But the key is the anatomy. If you can demonstrate anatomy, that's, in my view, is the best way to do it. Counter traction. Traction with a cuff of peritoneum. Air. Air holds the key. Then you all the way down now, look. Slim person, easy to go here. You should not be seeing this fascia, which is a presacral fascia, has to be left intact, covering the pelvic floor and those vessels that I'm just showing you. The specimen starts to come forward. They can move the, okay, well, I don't know whether they can move the video slightly forward. Again, very, very boringly similar way, hitch the base of the bladder up. And here, there's a little things, hold the needle from the tip, because if you hold it from the back and you're taking it out, it can go into the pelvic side wall, touch the vein, touch the artery. Small things, really small things, but they can really spoil your operation. Suddenly you're doing something and you're talking, and suddenly the needle have gone to the pelvic side wall. So again, hitching it, and you will see what I mean by repeatedly showing you the same thing. You could see this is the hit. Okay, another practical tips. In obese people, sometime if you only put one suture, the tent become much more narrower. So in obese person, sometime I put 2, 1 on each side. So you stay like this rather than like this tent, because that would make it more difficult to go in the deeper access. So, this is just a tip for hitching the bladder up. Again, counter traction, traction with the left hand, nerve package. Yeah, now this would be interesting. I hope this will be the same clip, but just focus on the specimen. See how it gets released. Just keep looking. This is the Denovelius fascia anteriorly. It starts like a U-shaped fascia on the edge. You could see staying outside. If the tumor is anterior, you want to stay here. If the tumor is posterior, you can go across this much earlier. Left nerve, again. See this? Now, you have to remember, I did lots of these. I made a lot of mistakes to come to a method of doing it, right? So when the guys with the robot came and they say this would completely change your life, you have to ask yourself what it would change. So that's why I kept saying to you, the gains have to be marginal, and the marginal gain come from repeated hours of practice. Look at this now. Look at the specimen here. See this, how it get released? Back, forward, back, forward. And it's almost like the lower nerve package almost sort of come from each side of the specimen. We know this. Look how it is being released slowly. And now I'm going to divide the Denovelius fascia to go across that. Hopefully it's the same video, but you will see it very, very clearly. The group in Oxford, they never believed in this fascia for many years. They said this does not exist. while Bill Heel keep telling everybody this is fascia which is there. And now the technology improved and high definition comes in and 4K come in and everybody can see it. Then suddenly they say, yeah, maybe it is there. So again, circumnavigating it, going round, 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 boringly same way. So once you have released the back, the very last part, as you are saying, that you have to sort of release this enococcygeus for this to be stapled. Again, follow the air, keep circumnavigating it. This is it. Look. So this is the same reason, we are now as a profession looking at TME technique, for example, and I don't do TME, so I would not even pretend to give you any insight into the technique or things. All I know is people who do it, they say they do it because they could not see better at the lower third, and they would have better CRM and they would have a better anastomosis. These are the two things people sort of changed it for. Our own president of Royal College of Surgeons many years ago wrote an editorial in British Journal of Surgery, and he described something called no man's land. If you look at this is Denovellius fascia being divided now. This was a tumor around here, so we kept the intact fascia. Now we are fusing at the back of prostate, so we can divide it. Look, just like that. And it would go away from you because it is at the back of the prostate. Now, I was telling you about this no man's land, and he sort of wrote in that paper that in every male pelvis, there is an area that exists where no laparoscopic surgeon can reach or see. And he described a procedure which was at that time known as a pier procedure, right? And he was coming from below and doing it. I really have not seen the pier procedure. I have not seen an area called no man land. You can go as low as you want from above. There has never been a problem. And the only rate limiting step is if the tumor is on the dentate line, then you might have a difficulty stapling it, right? And then you can sit between the legs and do what John Marks for years have been describing called Tata operation, transanal resection of the tube, so to speak. So two firing again the same way, front to back, and I'll just you can move it forward so we can finish off by showing you the last case. So if you move the video forward gently, slightly, because I think it is not very well edited. So you can move it forward, please, if the technician is listening to me. No, maybe he's not. Okay, doesn't matter. Again, the important thing is two firings, 45 each, turn angle where the apex is, and divide it at this level. Don't have a step between the two. Okay, so you can divide this, and then I would cut this edge off, and I want to show you the end result, because a lot of us are very keen to look at the specimen, and we always admire our work by looking at the specimen and say this looks good. This is half of what I describe the TME is. The surrogate marker obviously is the specimen shape, of course. Have a look at it. It should be nice, complete, shiny package, as you would expect, all the way where the staple line is. But most importantly, you should also look at what you're leaving behind. And what you should leave behind is intact presacral fascia and the two nerves between the two. So let's look at the last video. This is a really technically challenging guy, as we as a surgeon would call it. Somebody who had a BMI of 40 odd. He had chemoradiotherapy given and he had a complete response. And then 14 months later, he regrew. And one of the pleasure of working at Lisbon in Portugal was that they have a huge wait and watch program. The downside is that when the tumor regrow, they ask you to operate on them. So you have to then be prepared to do operation on all these patients. So have a look at this guy, please, the third patient. This is someone who have regrown 76, 14-month post-op, have a tumor regrowth, cardiac stent on warfarin, very low tumor, you know. So this is again less photogenic now because this is 1 year following post-chemo radiotherapy. You could ask me why we are not doing it robotically, because the guy did not have insurance to cover the cost. And I kept saying that you can do the same operation laparoscopically. So the Bill Hill said to me, well, you should be able to do it. So, so that's how we are doing it. See how narrow it is at the front, less photogenic because a lot more fluid, less spaces to go around. Again, you can, if you watch very closely, you are able to differentiate the air that exists between two embryological planes. Some patients have this pre-sacral fat pad. It's very easy to go deeper to this. And you start looking at the veins posteriorly. Again, the same pelvic right side wall. Under the seminal vesicle, see that? A lot more trouble for the guy to show me because there is not enough space for him to work with. But the concept is exactly the same. Counter traction with a little pledget, dissecting with a hook where the air join the two, posteriorly now again, doing effectively the left side from underneath before you move on to do the left side now. Again, very, very similar approach. Big guy, yes, but it should not change anything. If you look, hopefully you would notice that it just become the same operation that you have seen in the last two videos, be it with bit more challenge for the operator. Again, see this? Air. Air is the clue. One of the bigger problem with monopolar diathermy and a small pelvis in a post-radiation is the smoke that it produces, because you have difficulty seeing in a narrow space. This is the left nerve being separated now. Look again. There it is. Again, gentle counter traction. You don't have to make a plane. The anatomy exists. You just have to join the two. Going deeper and deeper, staying at the upper end of the white. You can just about see the smoke become a problem for the guy to show me, but it doesn't change anything. Just sticking around right nerve, staying inside the right nerve package. Bit more fluid as you would expect with radiation, but just follow the specimen all the way down to where the TME finishes. There it is. Now, once you have very difficult access and you have difficulty with a lot of fat and you don't want any fluid, you can of course use harmonic scalper, to give you what you call sealant effect of the tissue. But again, it's a very, very similar operation, regardless of what the patient is presenting as a challenge to you. Traction, counter traction, staying underneath. All the way down, all the way down. You have to release this from the inococcygeus again. There. So patience, eventually everything gives up. You just have to have a patience that following the anatomy rather than creating anatomy. That's the word I often sort of say. Don't create something which is not there. You just have to find which is already built. The left neurovascular bundle is quite prominent coming down. The camera person is struggling, but he has to show me the pelvic floor now for you to join this all the way down. There it is. The pelvic floor come into the view. Again, beautiful instrument because it can seal the fat if you are struggling. Again, follow the back. Back holds the key. If you look at posterior side, that usually gives you a clue where the pelvic floor is. See the problem with the smoke? So you need to have a big high-speed smoke evacuator if you're working in a deep pelvis like this. All the way there, joining it now. You're almost sort of finished now with the TME is finished because there is no more fat layer to keep going round and round and round. And it's a low tumor, so you have to have a very experienced finger checking the bottom end before you think of stapling, because if you have any doubt, you can do transanal intersphincteric resection and take the specimen out from below, which I was alluding to. But this is the decision you have to make before the operation, that this is something that you can staple from above rather than, making it at this stage. Look, there is the pelvic floor now on the left side, back side, right side. You can see it. Now, this is the final preparation to basically prepare the tube to staple. There it is on the pelvic floor. There. And then, of course, as you would say, this is it now. You are down. You can do the PR examination, make sure it's all okay. And then, of course, this is the best stapler to use. The green cartridge on post chemoradiotherapy rectum. Two firing still. This is Echelon gun, same principle. Advantage perhaps with this gun is the tissue stays within the jaw. This is my appreciation of this. Look at the specimen. It should look exactly the same way. Nice rounded specimen. Staple line is front to back, and mesorectum finish where the staple line is. So you're not coning onto the tube, which is an important thing to remember. Look at the specimen now. It won't even go where it's come from. Okay. So this is the bottom end. You could just about see where you have divided it front to back. Okay. So I think if you have comments or question about laparoscopic technique, we can share some thoughts now, and then I go on and show you the same operation with a different tool.
Yes, we have some questions. I remember. I want to say some words. I remember your surgery in Dnipro, Ukraine, 1 year ago. It was very challenging case, and in addition to the surgical technique, it's very important to be very patient in achieving the goal. And the different patients, different conditions in the pelvis, and one standardized surgical technique. It's very amazing. It's your school, and we love it very much. All genius is simple, and your surgery confirms that. It's a great pleasure to watch and learn from you. And some of us have questions, and now I would like to ask Ilya, and he will answer you some questions. Ilya, go on, please.
Thank you for the excellent video. And I have two questions. And the first one, especially for our Russian surgeons, in your opinion, is it better to preserve the left colon artery or high ligation of anterior mesenteric artery with mobilization of the splenic flexure? What's the better?
Okay.
Your opinion.
Okay. So this would have two-part answer. The reason we do high ligation and almost always mobilize the flexure for TME patient is because in Britain, where I trained, most common patients, we have a lot of diverticular disease in sigmoid, and they usually have, the population for some reason have got short sigmoids. They don't have long descending colons. I started traveling from 2007 onward, teaching around the world, and I noticed that demographically, in Russian patients, for example, and in population in Iran, they have very large descending colons congenitally, and they hardly ever mobilize the flexure, both surgical groups. So when you arrive there, it is perfectly reasonable to not sacrifice the left colic and do a distal ligation, because we know now that oncologically speaking, it makes no difference in terms of lymph node harvest or oncological outcome, whether you do high tie or low tie, as long as you have done all the lymphadenectomy around the main. And so most Russian surgeons and most Iranian surgeons for that matter, and people in Amsterdam, this is a common practice in Central and Eastern Europe and Amsterdam as well, where they take distal IMA or they always spare the left colleague, but they hardly ever mobilize the flexure. Now, because if you think about it, mobilizing flexure is just for the technique of having a tension-free anastomosis. So, if in your population, if the same purpose can be served with a very nice floppy sigmoid or descending, I beg your pardon, with a big loop, then it served the purpose. You don't need to mobilize flexion. I know now that some of my Serbian friends, they don't have to mobilize flexors as well. We did a lot of these workshops, we operate. Some of these patients have got a big, large loop. Now, because if you have a large sigmoid loop, it is of no consequence or no advantage to you, because as soon as you've done the high tie, you almost have to sacrifice all of the sigmoid. Then you have to mobilize flexure. So in a way, what I'm trying to say is that if in a local practice you spare the left colic and you don't mobilize the flexure, it is perfectly reasonable thing to do because that's the local demographics of the population. But if you are operating on a patient who have not got a long sigmoid or long descending, you must have a skill to know how to mobilize the flexure. So I would train my trainees still in how to mobilize splenic flexure. I remember going into China a few times and operating in some congresses and some workshops and everything else. They always ask me, why do I mobilize flexure? Because they say it's very dangerous step of the operation. This is because they always save left colleague. They always take very distal IMA. So I would always train the trainees. I would encourage you guys also to train your trainees in a technique of mobilizing splenic flexure and then develop their judgment to make that call based on individual patient to say that whether they have to save the left colleague or whether they have to take the IMA.
Thank you very much. And my second question, especially for Russian surgeons too, do you find it appropriate to suture the pelvic peritoneum and drain the pelvis through the perineum?
Yeah,
we saw
okay, I
a
know.
few days ago.
Yes, yeah. I have never done it, and I really don't think so. This would stop the leak because we all know
I
that.
suppose, Amjad, I suppose it's time to begin to do this,
Fair enough. Fair enough. It is. I'm always happy to learn, and to be perfectly honest, I learn a lot from the students I teach because for me, they are my teachers in a way. They are telling me something different. So if I propose the change in my philosophy, I should not be scared of the change. So if this is something that is important and minimize whatever we have, of course. I know this that the surgeons in China do it for years. You know, they do the anastomosis, they close the pelvic peritoneum inlet by running suture, and they put a drain from below and above, and they say their argument is that if the leak happens, it's very contained. This is the argument they give. Um, I personally have not done it. I know my anastomotic leak rate, it is under 3% for all comers. I could never bring it to 0%. Even if I take the radiological leaks, for example, they are under 5% if you take all the CT abscesses. I'm slightly biased because I do unselected loop ileostomies. So I would never know maybe the consequence of subclinical event. So if by doing that exclusion, we stop doing stomas, for example, or we start doing selective ileostomies, and we say this is what was change the practice, then of course it is worth pursuing it. I personally don't close the peritoneum. I leave a non-suction drain from above, posteriorly behind my anastomosis, and I do loop ileostomy unselectively for all TMEs.
Thank you.
But
Thank you
Ilya
so
would
much.
suggest the study and we'll participate, I'm sure.
Thank you, Amjad. I know that Badma has a question, and please, Badma, we're listening to you.
Again, my dear friends, and for the wonderful conference. The question that I have is very simple. When you consider a student, your alumni, to be enough trained to do surgeries without number, is it your personal feelings? How do you define that?
Yeah. It's you see, Badma, there are never simple questions. There are
I know.
always
I'm the
uh, the, the questions are always very intelligent. The answers are stupid. So I think what you are saying is hugely important, because in the end, like you said, is it a subjective assessment? Is it the assessment that, oh, I think it looks okay? No, it doesn't work like this. So we in LabServe, for example, the same principle, in LabCo, the same principle. We did a lot of work about objective assessment of monitoring the training, and I would encourage our group in Russia to incorporate that when you start training your fellows. So you have a global assessment score sheet, and you have all the module of the operation. And when you teach the students at the end of the operation, you fill the global assessment score sheet in real time. So score of 0 to 5, 0 mean the training could not do the procedure and you had to do it, and 5 mean done without any input, close to perfect, right? This is the scoring system. So you score your trainees for each training episode. And at the end of, let's say, 10, 15 procedures, you want to find out where the score, the median QSUM score, is going or heading. Within the LabCo program, we are able to demonstrate and we are able to show, and we have published this from England. Danilo published that, and I think Hugh Mackenzie afterward did some work on it, that it took median of 21 cases for the trainee to start their surgery and come to the score where they are producing consistently 4 or above score in each module. So you are telling, I'm not just saying, well, I like this fellow, she's very good looking, she would be okay in 3 cases, you know. And this guy who's got a big beard and he's 6'5" and he always stand very close to me, he requires a lot of operation. This is the subjective assessment, which is not good. Now, this is very important for you as a trainer to have for 2 reasons. Let's say if I'm your trainee and I always struggle with splenic flexure, let's say, all right? So what do we normally do? We normally sort of say to the trainees, oh, you know what, you always take such a long time with this. Let me do this part quickly, and then you can do the rest of it. There is no learning for the trainee because that's the bit that he or she really want to learn. So you could, based on your gas score, say to the trainee before the operation, you know what, you are absolutely fine with vessel and mobilization, it's okay. But splenic flexure, you're struggling. Your operation part in this teaching would be splenic flexure only. So it gives you a tool to gauge the training, but more importantly, there would be in any assessment program, you have to be prepared. And I think it's for my colleague Artem and Ilya and the guys who want to run this fellowship program at the back of School of Oncology, and Badma to you. The trainees turn around and say, I am not progressing because these guys are biased against me. They don't like me. I come from, I don't know, far off area of Russia, and I don't fit in Moscow. And so this is your tool to sort of say, look, hang on a minute. This is your track record of the training. We have just not come out of the blue. So I think it's very important to do objective assessment and objective scoring as you train people. Of course, we all have a gut feeling and we say, yeah, he's ready or she's ready. And the idea is, if you think about the concept of score 4 and 5, which mean that increasingly you don't need to scrub. You can stand at the back let them do this, and then okay, I don't need to be around, and they can do it. So this is how it gradually transforms, except that you attach numbers to it, because that makes sense.
Okay. The question I had, and Professor Amjad brilliantly answered it. It's my message to all trainers, to all mentors that I see here. First of all, it's Ilya Chernikovsky, Leonid, Artyom, and I think Rustem and other guys are listening to us. Audition, checking the scores of the student are very important, but your job is to make that score more efficient and more even in every point. And Amjad just brilliantly answered to that. So thank you very much, Professor. We love you. You have huge army of fans, I would say, in Russia and post-USSR areas everywhere. Thank you.
I'm honored.
Padma, thank you very much. I would like to ask our Serbian friends if they have any questions. You can feel very free to answer it to Amjad. And now I know that Kirill has a question, and we'll listen to you, Kirill. Go on.
Yeah.
One question
Yeah,
for
Amjad.
Yeah.
First of all, I would like to ask a question from Facebook
Million,
page.
after Kirill, please. If you don't mind.
Okay.
Did you hear
Go
me?
on.
Okay.
Yeah, I can.
Yeah, we
I can.
stream now on Facebook in our group. So here is the one question: what is a better option in elderly patient to do lymph node dissection D3 and have opportunity to nerve injury, or perform lymph node dissection D2 and don't care about 253 lymph nodes? Thank you.
Yeah.
It's a question
Okay.
from Georgia, actually.
Okay. So, for me, I showed you the technique. I like to clip on the left side one artery and one vein, because in that way I keep my concept very simple, right? Which means that I always take the IMA 2.5 centimeter from the origin. It's just because of simplicity. That's how I operate, right? Again, it comes back to the same discussion that we just had. If somebody in Georgia, for example, or Russia or Iran or Serbia, or the patient demographic is such that they have a very long loop of descending colon, and their sexual function is very important to them, as most of the people who are sexually active, it is an important function to keep, then doing a distal tie, or sparing the left colic and doing the distal IMA, is perfectly reasonable thing to do in that context. But if you are asking my practice always is consistently the same technique. The only occasion when I have to take the IMA not flush is occasionally when the stump is so small on the aorta that there is a risk that you're going to end up making a hole. Then you say, okay, probably we can take distal IMA and left colic separately, because this is almost flush on the aorta. But that happened very, very occasionally. So again, not for oncological reason, the D3. I don't think so that D2, D3 makes much of a difference in terms of survival and long term. There is a lot of data people have been trying, and on the right colon there is Alexei Karachun is running a study, but their preliminary data sort of didn't show much of a difference. So I think it's to do with individual patient requirement, surgical expertise, and the functional preservation, because we know for sure that if you do a distal tie, you always have less chance of urogenital damage. They have published it quite a few times. Yes, Milian.
Thank you very much.
One
We have a question from Milian. Milian, please. You're welcome.
One question for Amjad. Which equipment you are using for gas and smoke and evacuation due to protection of COVID-19 infection?
Yeah. So these days, historically, we have used anything that was given to us. these days we specifically use this high-speed insufflator with a closed smoke evacuation system. It's made by, I think, SurgiQuest make it. We call it. There is a name for it. This is German guys who made it. High-speed insufflator with air seal. Yeah, that's the name. Yeah, it is commonly known as air seal. So yeah, it's a system that we use because it has a closed system smoke evacuation, and we also use a filter on a 5 millimeter port side on the left side. So when the smoke evacuation happens, it happens in a closed circuit, not in the atmosphere.
Thank you.
Thank
And
you,
before,
Amjad.
of course,
So,
before making an extraction site, you deflate everything first and then make an extraction site. This is a standard practice now.
The sages
thank you very much.
suggest, and okay, thank you.
I think Milan has 4K, yeah, and you have air seal device. Am I right? That Serbia has purchased a lot of air seals.
Yeah,
Yeah. Yes.
I
have
think
used
that
all
we, yeah, I think because of Miljan and Amjad, now we have 22, 23 hospitals with air seal.
Okay, good.
Lucky you.
For Serbia, it's a
So,
significant number.
I would like to say
They have
to you, my
hospitals
friends,
now.
that I would like to say to you, my dear friends, that we do not use any kind of very high quality and high progressive devices because we have no COVID in our country. So I just don't rather understand what you're speaking about.
That's a better option.
So,
That's a better option.
dear Amjad, we are looking forward to see your robotic surgery right now, and I would like to tell you a very short story. It was 2014 when, in my first life, I was thoracic and upper GI surgeon. And about 6 years ago, in 2014, I was watching to Белые ночи, the St. Petersburg's Congress, Oncology Congress, and about 6 years ago, I firstly watched your robotic TME. And through watching of the surgery, I saw that anatomic landmarks that make understandable for me the TME procedure. So I've never saw this anatomy during the open procedures and even during laparoscopic procedures. And this operation that was made in Dmitry Gladishev's clinic in 2014 was my first motivation and first inspiration for the rectal surgery. So I'm looking forward to listen and to watch your video presentations about robotic. So you're welcome. Please go on.
Thank you very much. I'm really pleased, Ilya, that I at least managed to inspire one person. At the moment, I'm struggling to inspire my children. They don't find it very easy. So I remember that this was Dima's hospital number 76, I think. That's the name of the hospital, I'm told.
No, number 40, for number 40.
Okay, I got
40.
the number. Yeah. Okay, well, let's start the video. Maybe we can start with this. Okay, so I'll show you a series of short videos of the robotics. So some of you around the world who are sitting watching this may have access to robot. Others probably are willing to buy a robot or thinking of buying a robot. This is an XI system, which would soon be available in Russia, I'm pretty sure. 4 ports in one line, and an assistant port. Exposure is done before you dock the machine. That's important to expose it. And that's the robot being brought in. This is, you can see laser guided targeting where you put it onto the camera port. And depending upon where you have put this camera port, you can either have 2 right hands or 2 left hands. Look, the machine does its targeting and it goes in a place where it becomes easy. So this is just for the demonstration purpose for you. monopolar diathermy in my right hand, fenestrated bipolar in the left hand. Now, the steps of the operation doesn't change. The anatomy doesn't change. I say boringly same things over and over again. So this is IMA. You asked me, I said one vessel front of the aorta because that's what I'm used to seeing and used to separating. Again, this is the left colic going off. You could see. If you can name the vessel, you should try to put a clip on through the assistant port, cheaper version, Hemolock. One for the patient, one for the surgeon, and one for the lawyer. It's important to sort of stick to three. Again, then you do medial to lateral dissection at the front of the gyrotous fascia or the top of the white line. Again, the difference really is that instead of doing this repetitive pushing movement that we all did with laparoscopy, it become like a painting exercise using the tip of the instrument. But the anatomy is exactly the same. Anatomy is not changed at all. It's just that view is different. The vein is taken very high again, the same principle. And next to the DJ, you can see the pancreas at the back here. Again, clip, and cut. And once you have divided the vein, then you can increase your traction on the curtain going medial to lateral on a white line. You can use it number of ways, although it's a scissor, but I use it like a paintbrush, I use it like a hook, and I can use it like a cutting device as well, depending upon what you're dealing with. Again, the pancreas come into the view, the plane is higher up. It's up there. I've just got to realize that this is slightly higher. This is the pancreas now going down, and you follow this air and leave the gauze at the top of the pancreas. Pancreas become much more. Half of the time, you are able to break into the lesser sac from here. If you could do it, great. It would just minimize your work from above. But you have to drop the pancreas a long way and then put a gauze over it to be able to see it from supracolic area. Now, doing the lateral mobilization, again, traction, counter traction. One of the downside which more and more trainees feel that they have limited role to play because everything is gone to the console and they have very little to do is not right. Because even if you come to console, you've got to be able to learn bedside assistance. I use my assistants quite a lot because I like to see things. So there it is, the gauze that you put on the other side, it keeps the small bowel on the other side as well. So it doesn't creep up. Sometimes the small bowel would come up and it become a pain for you to manage. We have integrated table motions. The robot is still attached. You can move the table just like laparoscopy without de-docking the robot, which means that you can do head up when you're mobilizing the splenic flexure. This is a luxury. I don't think so. This is a necessity because we did all of this with SI system for years and we were able to do it. Again, taking the momentum of the transverse colon, getting into the lesser sac there, and hopefully very soon you'll be able to see your gauze to complete the splenic flexure. Now, although I've shown you with robot, but you have seen this in my previous laparoscopic video, the same step of operating, no different. It really shouldn't be any different. If my expectation was that the robot will make a different operation, then I probably didn't. I always worry when some of my colleagues or trainees sort of say, I have never seen this with laparoscope. You always wonder what they were looking at. People should be able to see a nice anatomy even with laparoscope. That's the gauze there on the pancreas. And you can cut right onto the gauze knowing that the pancreas is safe. It's a very standardized approach to mobilize splenic flexure. Imagine this is done laparoscopically. It's the same principle. Now we put patient head down again. The small bowel can come out of the pelvis. And if you remember the videos I showed you with the hook and the pelvic dissections, this would be the replication of that. Left side is attached. You start posteriorly, so gently holding it to the front, putting it at stretch and painting, just using like a paintbrush exercise. subtlety is this, the subtle advantage to the surgeon, which you would appreciate, would be the pelvic right side wall, because now this instrument can turn backward and work inside the pelvic right side wall rather than a straight laparoscopic instrument, which is a challenge for obese person, not in a slim guy. But look here, follow the shape of the specimen, start at the back. Again, front I have marked, follow the air. So the counter traction is provided by my second right hand. So with this configuration, I have two right hands and one left hand. The camera is in number 2. The left nerve package, there. You will see it being separated. There. Just painting it inside the white. Follow the shape of the specimen. Why it should become anything different? Again, come from the front. There, staying outside Denovilliers fascia again. There it is. Just no radiation, very photogenic guy as you would expect him. Follow the air. So you see the assistant have got a suction inside. So he or she is constantly sucking the smoke, because that sometime could be a problem in a narrow male pelvis. You would see it in the subsequent videos. So again, the right side from the back, front now. This is the Denovilliers fascia outside there, and then you would go across this. I just touched it. This is the edge of the fascia, going across the Denovilliers fascia here. So the neurovascular bundle is here. If you stay outside, there is a risk of damaging, but you can divide it. And as soon as you have divided the neurovascular bundle or divided this Denovilliers fascia, you can stay underneath this, protecting this. You can see how clearly this layer is present in almost all patients. There, just staying inside. Now, this is the crucial part. Even with laparoscopy, don't come perpendicular down once you have divided the fascia. Try to stay parallel to your specimen, going above, sliding further distant. Because if you come down, you are going to come through the anterior mesorectum onto the rectal tube. Left nerve, low insertion, arrogant pillar, as Prof used to call them in previous life. So here, air, air, circumnavigating this. It's almost like very, very boring movie, but you have to play the boring movie in your cancer practice. If you have excitement in your operating theater, it's not good for your heart. So now the inococcygeus ligament being released at the back. You are looking 30-degree up view, supporting the specimen go forward, and you are separating it. You can actually go in the intersphincteric groove. Artem would tell you that, or Dima would tell you that if he's watching with a robot. It's very easy to convince yourself that you need to keep going, and you end up between the intersphincteric groove before you know it. So you have to release this. Now the sides. Watch this the left hand is crucial because it's such a strong robotic arm. You can pull the neurovascular bundle in thinking you have to go wide, and you end up creating a bleeding at this edge. I have done this at the beginning of my experience because I used to think this is a bit of a meso still attached on the side. And I remember very, very clearly in St. Petersburg, in that operation which Ilya mentioned, I was making that comment, but our colleagues were trying to tell me that you have to go wide. And then I took their advice and went wide and made something bleed. And then they said, oh, no, we know it's not to go there. So, so you can see, when I let go of this, it just goes away from me because it has come from the pelvic side wall. There, look, when you let go, it pings back. You will just see this now. There it is. The back holds the clue. Again, just joining this last few fibers, and then you would obviously staple it. You can do it with manual stapling, or you can do the same stapler with intuitive surgical makes, but it's still two firing, the same way, front to back. The specimen should be as you would expect it to be, but most important thing is what you are leaving behind. I keep saying, this is the crucial part. Left nerve, right nerve, and intact presacral fascia. You know, just on the floor, you can see the fascia is all intact. So we can play the second video. Yeah, this is, let's see, this would be done very quickly. So female patient, no radiation, very easy case, doesn't require robot for you to be able to do this. But the idea behind this is that I show you series of patient, but same operative steps for you to appreciate what does standardization bring. See the right hand, how it turn sideways and stay inside the nerve. In a female patient probably is not a huge advantage, but in a male patient this become a huge advantage for you to be able to turn the head of the scissor like a cobra head, you know, going this way and then going the opposite way. Again, done the back, stay at the back inside the nerve package. You saw me do this with the laparoscopic hook when I was doing the laparoscopic operation. Come from the side, stay inside. Keep staying inside. Back is the clue. Doing the back first, then joining the right side. Again, traction, counter traction. I have two right hands. So the second right hand is pulling the cuff up for you to be able to see this. Now the left side marking. Again, very, very similar operation. Just follow the shape of the specimen. The rounded shape comes to you. Everything else goes away from you. And if you notice bit precisely, it's the air that I'm after. There is an air that exists between the embryological layer. This is the back of vagina coming in. I'm just taking some fiber of that, I think, because you should see air here very, very quickly. Pelvic right side wall, not a challenge in a female patient. Slim person, not an issue. Again, edge, you can see the Denevelius fascia here as well, as you would expect it to be. Anteriorly covering the mesorectum. Now you're just going through this. Look at the back all the time. Keep looking at the back. This is the left side now. See the subtle advantages, the marginal gain that I refer to. You know, I'm able to have a very static camera. I'm able to change the tip of my scissor depending upon which direction I want to paint it. And although I have a scissor, but I'm literally using it like a paintbrush. So some of my, this is again looking 30 up, releasing the anococcygeus ligament. Same principle, no different with robot. Some of my colleagues who are very good laparoscopists, they think that this would be very difficult for them to make the change to robot because some of them are used to using energy source and they become a bit nervous using a monopolar. But all who have changed, they have noticed that it was very easy for them to change their practice. You know, we worry about things too much. Again, intact presacral fascia covering the presacral veins, both nerves in the right place. You should not be seeing them exposed hanging in the air because that means you have gone through something. So let's look at the third video, please. Now, this is an interesting video. No, you can omit this. This is just a repetition of the same. This is a male guy with no radiation. It looks very boring. Let's go to a different one. We can go to the next video, please. You can come out of this. Yeah, this is. So this is a big guy, again, who got regrowth, difficult, challenging pelvis, post-radiation almost a year before. So this is a challenge, and this you might notice that this is where the advantage of all these marginal gains come into the play. I do the back, then touch the side wall. This is the back, the nerve is at the back. You could see this. This is a biggish guy with radiation-induced edema and bit of a fibrosis. Stick to the top of the white. And if you keep looking at the tip of the scissor, it does this way, and then it goes the opposite way, just like a head of the cobra. This is the right nerve, and you stay inside that. So that's where the gains are. The gains are marginal in these patients. You see this right side now? Inside the right nerve package. You saw me do this laparoscopically, and it was a challenge to do it. I would be the first one to admit, So as a surgeon, it makes my life easy when I have a view like this and when I have a tool like this. So again, look at the front, narrow front. You are marking the peritoneal reflection again, staying underneath this. I always, you notice, leave a cuff of this peritoneum because I want to hang on to this, because this would be a good way for me to move. I do almost like peritonectomy, effectively at the peritoneal reflection. Now, this is, you will see, counter traction under the seminal vesicle, and I would stay outside the Denovelius fascia again. Narrow space, really narrow space in post-radiation. An interesting observation I have made is that when you operate after post-radiation, 6 weeks, you have a lot of edema. You operate 14, 16, 18 weeks, you have a lot of fibrosis. But if you leave 6 months or more, which I happen to operate on these regrowths, sometimes the edema and the fibrosis is not so bad at that stage. For some reason, body tend to sort of compensate for it. This is the left nerve, anterolaterally, just releasing, just there. And it has to go away from you. You can see it has to go away from you. Now look at this. This is the Denovelius fascia, which is intact. And concentrate here. There is a vessel here. You will see the pulsation when I divide it. This is the neurovascular bundle we often make bleed when we are on the sides. And suddenly we say, well, look like a lateral ligament. Give me harmonic scalpel, and we sort of buzz everything and it looks good. But if you keep looking at it, you would notice this. You would see there the pulsation to the very right now. When I divide this fascia at this level, keep looking. Here, there is a pulse here. See? So you go under the fascia. Look how I'm circumnavigating the specimen in a small windows where I work. I divide the Denovelius fascia again. There you are. And once I've divided it, it becomes relatively easy for me to stay under the fascia and follow this air. See this? Don't go down. If you go perpendicular down, you will end up damaging anterior mesorectum. Go parallel with your specimen. And that's what robot allows you to do, because your instrument can stay parallel to the specimen. This is the back again. Supporting it forward, painting inside the white. Just separating both pillars. Inside. Look at the neurovascular bundle here. Stay inside. And what I'm looking for is the back as a reference, because I put the gauze right there where the floor, where I stop my dissection posteriorly. So I have to stay at that level. Keep following it. There you are. Now I should be able to see the pelvic floor from the right side. There it is. It would just come into the view now. There, I just touched it. That's it. It goes away from you. That's it. There you would be able to see it much more nicely now as it goes a bit deeper. There it is. Yeah. So you stay inside. This is the insertion. Look at that. This is the insertion of the tube in the pelvic floor on the right side. Same thing going opposite way. Now you just follow it going the other side. So look, when I looked at it at the beginning, it looked like a real big challenge for me. But I don't look at the end. I really do them in a small steps. I just focus on the next step of the operation and I try to do that well because I know that if I join all these little dots, as I call them, the end result would be exactly the same. End result would be that I'll end up with no mesorectum to operate on and onto the tube. That's how I think. And I think this is what I would like everybody to think, that when you're operating, just concentrate on the bit which is right in front of you. Don't think ahead, whether I would get there or not. Don't worry about it. Again, right there, onto the tube, separating from the neurovascular bundle. I remember operating in front of the audience for this case, and they keep sort of telling you to keep going because they want you to sort of screw it up. And you have to keep telling yourself, you are following anatomy, not the audience. You all have to do, look at that. This is the pelvic floor being separated from below, inside here. That's the endopelvic fascia approaching. The risk at this stage is to make a hole at the back of the tube. Laparoscopically, it's the same risk. So always be careful not to make a hole at that level in the tube because that's a disaster. So again, separating seminal vesicle and a prostate from the tube completely, and then when you sort of staple it. So it probably would finish, and I'll show you the last video before we have the discussion. Okay. So again, circumnavigating it all the time there. And neurovascular bundle is pulled in. It's very easy to pull this neurovascular bundle in with a strong left hand, and then it bleeds. See that? I'm just saying the same thing. You pull, you release. So you almost have to look at the shape of the specimen and take a clue posteriorly where the insertion is. There it is. And I think at this moment, a very famous finger of Professor Bill Heel is probably trying to get into the bottom end. And you're trying to tell him not to push because you're worried that you're going to make a burn onto a very important finger. There it is. So all the way down into the intersphincteric groove. Okay. So okay, again, this is the, like audience telling you, why don't you do a bit more at the back? And you sort of come back to the back. Okay, this is the peritoneal reflection. This is the nice specimen. This is the last video. This is an operation done at the beginning of the year before COVID came in. This is done in Karachi, the country I come from. And these are my colleagues who have got a colorectal unit in civil hospitals. So they asked me to operate on somebody who is only 28, post-chemoradiotherapy. She probably had to wait longer for me to be in the country to have her operation. So this is sort of 15, 16 weeks post-chemoradiation. The quality of radiotherapy is not very good because you will see a lot of edema. Again, both nerves and suction device for the smoke. I would like you to sort of focus on this just as a part of a technique, really, that how you can, what I'm trying to say is that don't make anatomy. The anatomy is already there. You just have to find it. And this was a long day for us. I remember we had done first operation laparoscopically, and then they wanted a robotic operation late in the afternoon. And one of my colleague and friend from UK who had gone with me sort of said to me, just try to finish this as soon as possible because, let's finish this and we have a faculty dinner to go to. That's what everybody like to think, and I was thinking partly like that. But then you have to realize something which is really an important thing for me in my practice, that for me this is perhaps 900 plus robotic operation or 1000 plus laparoscopic operation. It doesn't matter. But for the patient, this is the only operation that matters to them. You know, so I may be in a hurry, I may be guided by other factors, but the patient you're operating on, this is the most important time. These 2 3 hours that you're going to operate on them are the most important time of their life. So never have this prejudice. This is the message with this sort of video. I started off trying to do this very fast. I didn't show you the abdominal part. I was going like not talking to anyone, trying to do this very fast. As soon as I came to the pelvic part, it just occurred to me that this is not the justice. The patient really need all your attention and focus. And this is one of the unspoken advantage of robotic technique, that although you have mental fatigue because you are concentrating very hard, you don't have physical fatigue when you are doing the second or third case, because you've been sat down, you have operative atmosphere that you can control. So, but people who sign the checks, they really are not interested in surgeon well-being. They will tell you it costs you money, and it doesn't matter whether you have a neck pain or pain in the back. We will replace you very, very quickly by somebody else. But this is true for something like this. I still do a lot of laparoscopic work. When I operate 2 rectums in a day laparoscopically, the second operation is physically challenging to do. You can't pretend that it is. But if you ask me, and if I ask all of you as a surgeon, you would always say, yeah, I'm fine, absolutely fine. I can do another one, because we are programmed to say this. We are not programmed to say, look, I'm really tired and I can make mistakes. I record everything in my career, and I look at all my mistakes. I look at lots of videos even now for people I have trained. And I notice that when you are tired, you don't become bad surgeon. You just make bad decisions during the operation. So I think this is the key to remember, that and somebody wrote a very interesting thing a while back when he describes surgeon as elite athletes. And I look at my BMI and I think I'm not an elite athlete at all. But it's the philosophy of being an elite athlete, mean that you are focused 100% of the time when you're operating. And you are trying to improve this each time I operate. I really have not done a perfect operation. I still have a lot to learn. I still learn from my students. When I watch them operate, I look at my own operating and I learn. People around me sometimes don't realize, they are just happy the operation is finished. I know what mistakes I have made, and I know how I can do this better. So I'm trying to say to you is, have this philosophy in the way you operate on people. So this is a young girl with T3D tumor, but I must confess the quality of MRI report is pretty bad. It was just reported as partial response, and it was reported as something they call mural thickening. This is the report it says, but actually there was a significant tumor still inside the specimen. So again, back is done. Again, have a look at this. Just concentrate on this part, how I'm staying inside the nerve package. And you saw me look at the specimen, watch the specimen being released. You watch me do this with laparoscopy, coming to the right side and patiently taking your time, letting the specimen release from this neurovascular bundle. There. Again, there. The specimen just get released as you hit the right air coming around from right to front. So this is the point I was trying to make at the beginning of my presentation, that Homo sapiens are exactly the same. The cancer in the world, wherever you operate, always does the same predictable thing. It kills people. So you should not change your operation because you happen to be in Karachi now and you are in a hurry. and not many people do robotic surgery, and they would not be able to know whether you are outside the plane or inside the plane. That's not true. My goalpost really is my students. If my student don't find my operating up to their standard, then I've lost it. So that's why whenever I operate, I always have my students or trainees as a benchmark to say they're going to be looking at this and they be thinking, is this the operation they should learn? And I think this is something that have kept me interested in operative techniques, because otherwise it's a very boring two operations I do. Either I do left side or right side. I'm not a multi-vessel surgeon, as some of you guys are very, very talented surgeon. You know, you do chest and you do stomach and you do all other things. So have a look at this. Staying inside, just painting. Repeatedly. The left hand is holding it, supporting it. It never holds anything, because otherwise you're going to traumatize the specimen. Look at the back. Come from the back. Bill Heel said to me many years ago, when I used to be one of the many trainees who came to Basingstoke, and I was the guy who used to stand between the legs to hold this St. Mark's lip retractor, you know, and I never could see anything, to be perfectly honest with you. And they would, each time I would try to sort of go in, they would always push your head back and they say, no, you need to stay out, just pull. And whenever they would say, I think I'm below the tumor, I would be the first guy who would agree with them, because I was so fed up holding this bloody thing, you know, pulling it, because I always tell them, I think you are below it, just staple it. uh, Bill Heel always used to say, and still says, the posterior dissection hold the key for circumnavigation of the rectum. So whenever I'm lost here, to identify what I call the U around it, I describe something called yellow side of the white. If you look at the white pattern, there is a yellow side of this white, and you are painting that. There it is. Okay, I think you got the gist. It's very boring, and I like you guys to talk and discuss and things. You can stop the video. It's okay. Thank you.
Amjad, everybody's enjoying.
Okay, if they're enjoying it, then it's okay. You can let it run. It's not a problem. So here, vagina comes into play. People who are less experienced surgeon come to the middle and then go to the side. And if you look here, I'm constantly looking at the pelvic side wall. Just one layer at a time. Paintbrush, paintbrush, paintbrush. Take all the meso with me. One of the common reason to have local recurrence is the mesorectum that you can leave behind, the residual mesorectum which the surgeon can leave behind, thinking you are below the tumor and it's okay. You know, if you look at the Dutch TME trial data and the recurrence pattern, they did MRI on all the recurrences and found out that's why patients had recurrences. So take all the mesorectum with you. Anteriorly here, separate the vagina posterior wall a long way, because it would also be useful way, so it doesn't come in your circular stapler when you do the stapling device. Okay. Again, look at this as a minimally invasive technique. Don't get occupied that this is only possible with robot. Of course, it becomes easier. I always say a difficult operation remains difficult. It may become less difficult with good technique and good technology, but it never become easy. If somebody says to you, oh, it become very easy with this kit, you know, they are trying to sell you a pokey pie. Don't believe. Okay, so we can stop that. You're all the way onto the floor. Good. And again, releasing the back. Okay.
Amjad, what do you think about role of the robotics in abdominoperineal excision?
Oh, well,
Is it some advantage?
yeah, no, it is the same thing. For example, you know, we went through the phase where we were doing what we describe as extra levator APR. If you remember, that concept came in, and with that concept came this idea that you should not go low enough from above, because otherwise you'll end up coning the specimen and you will have the waste for the extra levator part. Now, a lot of people now have published and suggested that not every patient require extra levator APR. So people are doing what they call tailor-made APR. So they go wide on the side where they have they go wide on the side where the tumor is, and they go distal on the side where there's no tumor, for example. They give you this idea. But for me, really, the crux really is this, that if you are doing, this is, by the way, a different specimen. This is in Lisbon. If you remember, I think it was the time when we had this angel and demon meeting. If you remember, we did a really nasty sort of case. No, not angel and demon. I think that was the name. Fibrosis or whatever. This is mesorectum from there. Anyway, so my idea is very simple. If you're doing an operation which is functional, for example, APR, you're doing it because you don't want to go and join patient because they have bad sphincters and they would have bad function. You can almost do all part of APR from above with a laparoscopic technique or robotic technique. We know this. People have done this. They have published it. But if there is a posterior tumor, for example, in a male patient, you can go anteriorly much further using laparoscope and robot, because that's not where the cancer is. Cancer is sitting posteriorly. You don't have to lift it off the pelvic floor. Leave it there, but go anteriorly a long way. You're not going to compromise your cancer operation. You're not going to waste the specimen, or you could cone the specimen at the waist, but you'll make your life easy. My practice now is, if it's a male patient and we are doing an abdominal perineal resection, we turn them on the face when we do the perineal part. And it is because the access is easy. I learned this from Ayhan Kuzu, cadaveric dissection. I went and watched him and help him. And he was learning laparoscopy from me. I was learning anatomy from him. And he made it very simple in my head how to do extra levator APRs, prone, face down. And so I choose patient to do extra levator based on the location of the tumor. And I don't stop. Some people would say they stop at the tip of the coccyx posteriorly, they stop below the seminal vesicle anteriorly, But if the tumor is on the posterolateral side, on the right side, what difference would it make if you keep doing the dissection anteriorly outside the denovilliers with laparoscope or robot, because you have such a nice view? Do it. You're not going to compromise anything. But certainly don't come coning where the tumor is, because that's where the risk is.
Thank you.
Amjad, thank you very much. And our audience have some questions about the robotic total mesorectal excision. You have the second fan in my family. My daughter loved your surgery, and the taste should be installed from the childhood. And I couldn't waste that chance, and I showed your surgery to her, and so she liked it very much. So I suppose that Artem has a lot of questions, because he's one of the most experienced robotic surgeons in the former USSR. So Artem, we're listening to you. Go on, please.
Thank you, Ilya. I have one more question to Amjad, and the same question is in the YouTube about T4 tumors and robotics and laparoscopic in rectal cancer.
Yeah, so we have actually, it is in the press now, our result for laparoscopy, not even robot. I'm looking at locally advanced T3D, T4 tumors done laparoscopically, consecutive patient, 400 plus series. We have shown that there is no difference in clinical outcome, margin positivity, and long-term outcome between both groups, locally advanced versus non-locally advanced. We did a propensity score match. Now, you have to be careful when you make statement like this, and I am no different. You have to remember that this practice is from a highly specialized unit. Since 2006 or 2007 August was the last time when we did planned open operation, in our department. So we have conversions, but small conversions. So our practice is mainly laparoscopist, right? But you, as a rectal surgeon, would also know the real goalpost for you to become confident in tackling these cases, either robotically or laparoscopically, is your MRI scan and your radiologist. So I rely very heavily on the judgment of my radiology colleague to say, this looks like clear margin, this looks like where the margin is close, this looks like complete response or no complete response. Certainly, if you ask me about the feasibility of doing this laparoscopically or robotically, of course it is feasible. It is safe, it is feasible, it has similar outcome in very experienced hands. I would not even advocate to the guys who are at the beginning of the experience. And how do you describe beginning of the experience? If I give you an example, you can look up on Medline and read a paper written by me for my boss as one of the co-author in 1999 2000 when I worked for Robin Kennedy. This is a publication in British Journal of Surgery, you know, and he was the most published guy and most experienced guy in the country doing laparoscopic cases. And one of the recommendation of that paper, it's British Journal of Surgery is a reputable journal, and one of the recommendation of the journal is that laparoscopy should not be attempted for post chemoradiotherapy rectal cancers. And this is based on our experience of 4 cases. He did 4 cases and he ended up converting it, and we came up with this. Not because he was not capable of, he was perfectly capable of, and he could have done more, and he's obviously shown the world that he could. But he's always used to say that when you want to generalize something, you must give a safe recommendation. And the safe recommendation is do lots and lots of laparoscopic cancer practice, develop your radiology department, develop your radiology colleagues who can guide you for locally advanced people, giving you a roadmap, then incorporate this into your practice.
Thank you, Amjad. There are some questions on Facebook and YouTube, and one of them is Alexei Sakharov asks you, he is our friend from St. Petersburg, how could I train my practice for the very precise slow surgery? Meditation?
Right. Okay. Now you ask yourself, what is the alternative? Alternative is you get angry, you get frustrated, and the outcome is compromised on the basis of that. So many years ago, when I was started teaching, early 2000, I had a choice to make, that either I could become frustrated or I could become irritated, right? Frustration is bad, because once you're frustrated, you want to sort of finish it to an end. So that's the joke side of things. But the most important thing is this, that including myself, lots of us genuinely think that every one of us is a trainer. To some degree, we all are. But we also have to recognize that not all of us are at the same level of patience, for example, to train others, right? And that's where the problem comes in, that if you are training in a system where you only have one prophet to follow, he might take you to the mountain and ask you to sort of jump, and you have to jump because you've ended up following one guy. And if you go around and watch other people operate, you are able to pick what works for you. So the culture really comes, if you ask me, the one thing that I would advise anybody on Facebook, YouTube, young budding surgeon sitting there, record your operation, videotape your operation, right? And then have the patience to sit down and watch your mistakes. This is what you have to do. You have to be self critical to put the benchmark. One of the key thing in life is that most of us, including myself, we all like to be slightly better than the colleagues around us, and then we are happy. We think, once I'm slightly better than everybody else, I'm sorted. That's not the way to think of it. The young guys who are sitting out there, my message to them is that go and find the boy or the girl anywhere in the world who does this better than anybody else and keep that as a benchmark. And really, I genuinely believe, for years, I genuinely believe that your limitation is how you set your bar yourself. Nobody else can do that for you. Nobody else can come and tell you, Ilya, you cannot do this in Georgia because you're not living in London or New York. It makes absolutely no difference. Some of the best surgeons I have trained, I have watched operate, they work in small units and in countries which they don't even speak the language that we are talking this in this webinar. It makes no difference at all, but they are very skilled because they're prepared to be patient, precise. They videotape. Alexei Karachun came to me many years ago, and then he took this ethos from us in St. Petersburg, that he started recording. And believe it or not, he and his resident used to send those videos online for us to critique for them, give them notes. So it does require a lot of patience, and at least, how shall I phrase this? Yeah, I'll phrase it very in a simplified word. Unless we are prepared to say that I don't know to the question that I really don't know about, and then say, show me how it is done, we would never improve. If I know everything and I can do everything in my mind, I would never improve. So this is something that all the surgeons sitting around the world watching this should take away from this webinar. Your benchmark is what you set it for. Never hide behind these little frustrations which comes in everybody's life. I am no different. I work with some very important people in my life. They were very kind, but I held camera for 76 cases, you know, and videotape all those 76 cases and then watch them every evening to make notes for my boss to show them how he can improve. you know it is not that it just happened. Badma showed a very nice slide with the iceberg at the top. We all are at the top of the iceberg in our own respective lives, but we all have a journey that we have come through. So don't be scared, to record and ask colleagues, ask Ilya, ask Artem, Badma, Mladen, bosses, people, look at this and tell me how can I get better. Because when you have a mindset like that, it would be very difficult for people to catch you because you are just competing with your own self, nobody else.
It's a great delight listening to you, Amjad, because you are just like a Bible. You are
Oh no,
saying everything
Bible
on
that have changed a lot.
you just saying everything that is. It's like the Bible for the surgeons, for the professionals. Thank you very much. Kirill
Pleasure.
has a question, please, Kirill.
Кирилл, звук.
Звук.
No, we can't hear you.
No, can't hear. Reconnect, please. Ilya, maybe
Amjad, you have. Okay. Artem, go on, please.
the question from the YouTube is the robotic is clue to narrow pelvis, and if you do not have robotics, is TME is the issue?
Yeah, no. So I would answer it in this way. The nerves are there. They are not going to change either with laparoscopic approach, robotic approach, open approach, or TME approach. They are not going to change. The question is, do we have a tool to find it easier or to find it more precisely? At the moment, coming from above, we can always see where they're supposed to be because we all have learnt anatomy this way. And we find it easy with a 3D high definition double camera with robot, for example, right? And that's why it would help when you're operating in a narrow pelvis with a robot. Coming from below, you can do the same thing. I'm pretty sure some of the people who do TATME, they do it very nicely. But this is a new anatomy that not many people are familiar with. And it is already beginning to show in lots of centers, that initially when my colleague said that TATME is going to give you better anastomosis because you will have a secure anastomosis and you would have a better CRM rate because you are going away from the tumor. A lot of the publication come out of the TATME technique have already shown that this is not true. Some of the largest series published from Barcelona, for example, have shown the CRM positivity rate close to 8%. And remember, this is selected group of patients, mid-rectal tumor females included. And some of them had distal margin positive as well, because of the weakness to the purse string, because the technique was evolving. People were learning as they were getting better. We also know that repeatedly the anastomotic leak rate is published around 10 to 15%. The Royal Humpus, Royal is one of the guys who's technically extremely good at, and their unit have published around 16, 17% anastomotic leak rate, even in the registry. So it hasn't solved the problem to say, well, this is the easy way of doing it. It's not. The reason you are trying to do it with open laparoscopic robot TATME is because it is a difficult problem, whether we like it or not. So I would say to people, become good at one thing. It doesn't really matter what, So, and then there's a second part answer to this, which is on a lighter note, not scientific note. When I lived in this country where I'm living now and watched laparoscopy come through, laparoscopy was in fashion. In meetings, people used to say, do you do laparoscopy? So you have to say yes, because otherwise you are not sexy enough. People would think not very much of you if you don't do laparoscopy. So we were saying everybody, yeah, we do laparoscopy, whether we do it or not. And then the laparoscopic TME become the fashion. And if you are not a lap TME surgeon, you are not really there. So everybody started saying, I do lap TME. The next phase came with robot. So if I don't have a robot, I am really not sexy enough. And people would push their administration to buy a robot. And believe it or not, in my country where I am now, people start writing like Amjad Parvaiz, laparoscopic and robotic rectal cancer surgeon. There is no need to write it. It is just the tool. And if you don't have money to buy a robot, you've got to have something, otherwise you become irrelevant. So what are you going to do? Let's do TATME. Because then everybody would ask you, do you do TATMEs or not? So if you haven't got a robot, you've got to show something. So I personally think all these techniques would follow the natural course and people would come to conclusion that this is all driven by individual skill of the surgeon. People doing TATME would produce excellent outcomes because they would do hundreds of these in a single center. But when you would apply it across the districts, you would see disasters like urethral injuries, nerve damages, prostate being shaven through. Same with lap TME and robotic TME.
Thank you.
Maybe last
Kirill?
questions from Scholarship.
Do you hear?
Thank you very much.
I
Are
can
there
hear
any
you now.
questions?
Yeah.
Kirill, please.
Yeah, Amjad. So thank you again for excellent video, and we all have something to strive for. Yeah, your tips and tricks are very well known, but rectal surgery is not on. As for me, I'm not. As you know, I'm not a rectal surgeon. Yeah, I'm from upper GI, but I have several questions. All of you know that in recent years, some TNT and watch and wait trials, have came out in Ukraine. As you know, as in most of post-Soviet countries, some surgeons have their own opinion without any trials. What is
Yeah.
your own opinion about watch and wait technique and TNT in rectal cancer surgery? And I know that your team have good results. So can you give us some comments? Thank you.
Yeah, so the first thing to say is this, that if we are going to look at evidence, then we have to look at the evidence with open mind, right? So we know now that there's a proportion of tumors who would achieve complete clinical response after chemoradiation. And proportion varies between 20% to 30% or 15% to 30%, depending upon what practice you look at, right? We know this. And this has been published, this has been looked at, this has been reproduced outside South America. That's where the whole technique started. People didn't believe it at the beginning, and then everybody says, yeah. Because what we were doing, we were operating on these patients and having the histology as YPT0, which means no active tumor. And we were happy. We said to the patient, we took it out, it's not going to come back. Now, when you look at data, 20 to 30% would be in this group, which would achieve complete clinical response. And when you follow them up long enough, which people have done that, 20 to 30% of these would regrow. That particular 30 patients at the start, which you separated, 30% of those would regrow. And they regrow luminally. We know this, that it comes back into the lumen first. Very, very occasionally, we have two patients in our data set. They presented with lung nodules and disease everywhere. You have to warn patients when you put them into this program. Now, one of the key thing in being a surgeon is that we are very good at convincing our patients for our prejudice. So, for example, if I am the surgeon who don't believe in this, wait and watch, I would tell patient like this, it is not there. The chances is that if I take it out, it may not be there. But the risk is if you leave it, you can present with disease everywhere. What do you want me to do? So the patient would always say, take it out, right? The same surgeon would argue and say, it is gone. If I do the operation on you, it would be unnecessary operation because there would be no residual tumor as far as we know. And operation has got complications, this. If it reoccur, we'll catch it early and I can still do that operation, but you may not need it 70 to 80% of the time. What would you like me to do? So it's a different way of looking at it. So what I'm trying to say is this, that if this program is real, this group of patients with complete clinical response are real, they should be given an opportunity with very informed discussion. Now, if you are doing this program, let's say, I just give an example in Ukraine, right, where you haven't got a robust system of having MRI scan every 3 months, endoscopy every 3 months, CT scan, finger exam. You don't have that protocol. Patient come from Dnipro to Kiev to you, and they can't travel every 3 months. Then it is bit difficult to justify that for that particular kind of patient, you know. And if you say, I better take this off because we can't follow these patients up. We have no idea where they would get lost into the follow-up. But if you have a system where you can offer this, and you have a center which would do this as a cumulative thing, I think we as a rectal cancer surgeon should be prepared to look at this as something that is here to stay, particularly when our patients are facing abdominal perineal resection. If patients are facing APR and they get complete clinical response, whenever I talk to them, not a single patient agree to operation up front. They all like to be in wait and watch because it has an obvious cost to it. So my opinion is it is here to stay. It requires logistics. It requires a specialized center to run it. And it requires expertise at the center because when they would regrow, Kilia, they would be technically very challenging operations. So you should be prepared to tackle that at that stage.
Thank you for detailed answers.
Thank you very much. So, thank you. It's I suppose it was a very nice webinar, and thank you for all participants. And thank you, especially thanks for Amjad. It was very nice.
Yes,
I would
pleasure.
like all
Thank you.
participants to say several words, please, and I would like that our Serbian friends begin this final speech. Please, you are welcome. You are the guest on our Four Surgeons Club, and we are looking forward to listen to your final words. Please, go on.
Thank you very much for invitation. It's really great pleasure to be again with my friends. And I just want to say that we all have a chance to enjoy in this very interesting discussion, and especially to enjoy in Professor Amjad talk. So for us, it's as a small country, it's a big, great privilege that we have a chance not only in a few university hospitals, but almost in all hospitals in our country to follow all that advices. And it's like a marathon is not short. How to say short walk for 100 meters, but it's a very long distance that we have to go if we want to make on the national level very similar results in all hospital. I cannot imagine. I probably that should be very difficult in Russia because there are hundreds of hospitals. We have only 40 hospitals, and it's much easier probably for us. And I'm looking forward to see how that will be look in Russia to make that high level and make that level similar in let's say 80 or 90% of hospitals in Russia. So it's almost question, and I'm looking forward in the future to see how that will be look in Russia.
Thank you
Thanks.
very much.
Thank you.
Thank you.
It's a great privilege for us to talk in this workshop. It's a really great workshop, very good energy. We like challenge, and Russia is very big country, and the challenge is big, and we are ready to help you together with Amjad to do because project in Russia will be very big, but we will help you to make success. Thank you very much again.
Thank you very much. Russia is big, but Georgia is a little like Serbia, so you can begin from us. Thank you very much. Padma?
Me?
Yes, you.
Yes.
Can you,
Yes,
can,
you.
can
You,
you
Badma.
speak? Are you Badma? Can you speak?
Yeah. Thanks. One,
Are you still
Ah,
Badma?
you cannot speak.
colleagues,
Okay.
colleagues, friends, that Carrera or brought a lot of troubles. I think it brought us a lot of opportunities. That COVID problem, we wouldn't have that Four Surgeons Club. And I'm raising my virtual whiskey glass for the club, for my friends, for the colleagues, and I'm sure that our friend Pavlenko is fantastically having us together, and he is always and here. Bravo, very happy to see you. Good.
Thank you,
Thank
Badma.
you, Badma. With a real whiskey glass,
Thank
you
you.
will be drunk in 1 minute. We know it.
Oh
Okay,
yeah.
Amjad, please say to us
Well,
several words.
I
We're
I
always
would.
happy to listen to you.
Okay. Well, first of all, I'm really grateful for you to have this four surgeon club, because it just become a focus for people to tune in and to be able to keep some sanity. This is the observation from outside. Uh, I always feel privileged being asked. People often ask me, what do I have achieved in my life? Going around to the countries that you don't even speak the language. What have you gained out of this? And when I look back, my only gain in all this is the friends that I have made all around the world. They are the real value for me. I land in any part of the world sometime, and I know there would be a smiling face standing who's happy to see me there. And this is a real virtue of having friends all around the world. So I'm very grateful, to see you all and to see that you are safe and you are doing well and you have aspiration. Coming back to what my Serbian colleagues just said to you, the reason really it worked in Serbia is not because Serbia is a very resourceful, rich country, and now they have 40 air seal in every hospital. No, it only
22.
worked because, yeah, 22, he told me. So um, the only reason it worked in Serbia is that they had group of 6 people who were like-minded and who wanted to bring the change. It only worked because of them. The ministry got off behind them afterwards. And this is the same thing I see when I see, all you young guys sitting around there trying to bring in this training program in Russia, for example. There is absolutely no reason why it would not work there, because you have technical skills, you have ambition, you have what you call, you can relate to people, you can relate to each other with regards to skill level. So I'm pretty sure this would work, this would run. And it helps with, I had a lot of help from my colleagues that I could just ask them to get onto the plane with me and hold the camera and talk on the lectures. And all these fellows who probably are sitting somewhere watching this, I'm ever in debt to them. So they came to me to Serbia, and I'm pretty sure my colleagues from Serbia would return the favor if they are asked, because that's the only thing I ask to anyone I train, that they must be prepared to train others. That's the only thing I ask. It really doesn't matter. So I am very grateful being asked to come and see you all. I am honored in many ways. And I have no doubt that, long before, when we all are gone from this lovely planet, joining our friend up there, there would be people like your daughter who would grow up and they would do this much better than any of us would do this. So thank you very much for having me.
Thank you, Amjad.
Yeah.
Lovely plan.
Thank
It's
you.
great.
Okay, thank you. Look after yourself, everybody.
So, my dearest friends from Four Surgeons Club, it's your turn to say several words about today's event, and I will finish with it after you.
So
Tamam,
I want to thank all our guests, Amjad, our new friends from Serbia. You have 20 air seals. It's 20 more than in Russia. We have 30 robots, but no air seals. So it doesn't matter. It's a small country or big country.
We have zero robots.
Everything will be in the future. I hope you're comfortable with us in our team. And see you again. We are waiting for you again for a new meeting with you. See you in Lisbon, Belgrade, Poole, Moscow,
Yeah.
and so on. Thank you. Ilya?
Thank you.
Thank you.
Thanks to all our guests. It was unforgettable. I really hope to see you soon offline, maybe. For the Four Surgeons Club project, this is a great gift and a great event. And thank you for being with us. Choose.
Na zdrowie. Na zdrowie.
Na zdrowie.
Thank you, Kirill.
I just want to thank everyone for participating in our webinar. That was great. It seems today was very interesting, and I hope that our viewers like it. Yeah, and I'm personally convinced that to start the laparoscopic colorectal surgery is necessary after some experience in laparoscopic general surgery. Yeah. And this maybe will reduce conversion rate and learning curve. So that's my just own view, my personal opinion. Again, thank you for great evening, and I give a last word for our Tamada from Georgia, Ilya Gatsadze.
Big man in the small country.
Big man in small country, yeah.
Without COVID.
Yeah.
Thank you very much. Thank you. Thank you to all our participants. Thank you to our audience. It was a great pleasure to be with you today. And it was our first experience of the English-speaking webinar. And I suppose it was a very nice experience. You know that this webinar will be reviewed for many, many times because today we have YouTube, we have Facebook, and it's a great pleasure that a lot of people all over the world will see this webinar because the main messages on rectal cancer surgery, TME procedure was announced today. And it's very nice that a lot of people can see this webinar further. Thank you for participants to our Serbian friends. Thank you very much. We are very excited by your experience, and I had a dream to visit you after the COVID events. It will be a very pleasure to come to Serbia. I have never
Yeah,
been
you
there
have to be
before,
ready for hiking,
Sure.
like Badma.
No problem.
No hiking.
No
I
problem.
heard you.
It's not for young guys.
Hiking,
Thinking
I believe
beautiful
that we
thing.
have a lot of familiar traditions because we are the Orthodox country like you. So I'm looking forward to visit you, not only to see
and our
to see
restaurants
Serbia
probably you will like.
Yes.
and to learn Serbian traditions. I also want to see your surgery. Badma, thank you very much
Of course.
for Surgeons Club. I love you and thank you. And the Amjad, my last words are for you. So
Okay.
you know the film Godfather.
Oh, yeah.
Unfortunately, several days ago, Morricone had died. The
Yeah,
man
they
who made
shot
the
The
beautiful
Godfather.
story.
I remember that
Yeah.
part.
Do you remember the beginning of the film when the Bonacera came to Godfather and asks him for the favor? So
Yes.
I would like to, for Surgeons Club, wants to ask you for one little favor.
Okay.
And are you ready to follow and make this favor for us?
Okay.
I really want you to promise in advance that you will do this. Are you ready for
Okay.
that?
Well,
Okay,
as long
thank
as
you.
you don't ask me to take the shirt off, okay.
So you know that you have to make all favors that it's okay. So you told that it's very necessary to type and watch performed operations.
Yeah.
On First Surgeons Club, we have a practice, and our audience sends us the videos of their laparoscopic colorectal surgery. So I would like to ask you to join one of our live webinars when our students will send us their videos, and I suppose that it will be the great pleasure if you discuss the videos of your students, of your fellows, of your pupils, on one of our further live webinars. What do you think about it?
So I would do this because I was really worried what you're going to ask me. So it would be my pleasure. It would be my pleasure
Okay.
to do that. Okay.
Thank you to all of you. Thank you, Amjad. Thank you for you, especially. Thank you for you. You are the surgeon, philosopher, mentor, and the painter. Thank you very much. Goodbye.
Like a
Bye-bye.
Goodbye.
Bye bye.
Bye.
Thank you.
Bye bye.
Thank
Bye.
you.